Hello and good morning, everybody. You're very welcome to the All-Ireland Obesity Action Forum, and we're delighted that the focus here this morning is on maternal and child health. I'm Aileen McGowan. I'm the Director of Nutrition at Safefood, and we have a really exciting lineup of speakers this morning, so I'm really looking forward to this morning's proceedings. For our online audiences, you can ask a question by using the Q&A function, and that's at the bottom of your screen. And if you have any technical issues, please use the chat function and we'll try to address those as quickly as we can. We do encourage you as well, everybody in the room and everybody online, to tweet about the event, and our hashtag is simply Obesity Forum. So we look forward to hearing some of the online conversation later as well. And finally, of course, this session is being recorded. So whether you registered online or in person, the recording will be sent to you once you've registered for the address. My first job, of course, is to welcome Niamh Arthurs. Niamh, you're so welcome. We're delighted to have you here from ASOI. Niamh is going to give you our opening address this morning. So Niamh, if you would.
Super. Thanks, Aileen. Super. It's always a pleasure on behalf of the Association for the Study of Obesity on the island of Ireland to collaborate with Safefood and with ASO UK for this event. And a lot of planning has gone in to ensure that this will be quite a fruitful event. And I don't say fruitful just because I'm a dietitian. I've intentionally included that word fruit because fruit is often linked as a symbol of fertility, conception, pregnancy, and parenthood or offspring. There's similarities throughout between humans and plants. So from trying to ensure that the soil is at its most optimum for our seed to grow, caring for the seed or the seedling, protecting it from harsh conditions, and waiting in hope or anticipation for growth and for the plant to bear fruit or flowers. Many of you who grow plants or people or are involved in that area appreciate that despite best efforts sometimes to have the optimal conditions for growth, sometimes it doesn't always work out. And that can be really tough. And the impact can be widespread. And not just perhaps a woman, but also on her partner, perhaps on men, all genders. And this is something that I believe needs to be spoke out about more. And I'm delighted that one of our advocates of the lived experience will be coming from the male perspective today at this event, because I think it's really important to include that perspective, which often is overlooked and not heard. Recently, I was in a maternity hospital having my own procedure, and I felt quite nervous, vulnerable, and I definitely didn't feel like engaging in conversation, which for those of you who know me is very unlike me. But like many skilled and trained health professionals, my team tried to put me at ease by asking me, "And Niamh, what do you do?" And I love my work. I'm really proud and passionate about my role as a senior pediatric dietitian and researcher in child and adolescent obesity. So that's what I replied to the team. And the remarks that I received in response to my role were very stigmatizing, very judgmental around obesity and around parents of children and teenagers who have obesity. And this is where I want to speak to the power of the lived experience here today. Because it brought the experience of a lady living with obesity to my mind. And I have permission from her to mention this particular experience here today. So this lady shared her awful experience in women's healthcare services and how she was treated based on her body shape and size and based on the fact that she had obesity, which included painful tearing. She was advised to lose weight and the procedure was abandoned. We, the ASOI committee, wrote a letter to the lead clinical director of this health service. And I'm just going to read out a few points that I believe will be of value to you, for you to hear. One of the aims of the ASOI is to work with organisations in Ireland to reduce weight stigma and improve healthcare experiences for people living with obesity. Weight stigma is pervasive in Irish society and unfortunately common in healthcare settings. It is often tolerated because of beliefs that shame and stigma will motivate people to lose weight. However, numerous studies show that experiencing weight stigma actively discourages people from engaging in behaviours that are known to promote health. In addition, weight stigma increases the risk of eating disorders, anxiety, depression, weight gain, and feelings of worthlessness, loneliness, and social isolation. We would advocate for a weight-inclusive approach to all healthcare screening and settings, and reducing the likelihood of stigmatising encounters related to body weight may promote increased uptake and attendance at follow-up appointments. We would urge you to consider that the provision of equipment and expertise that supports women of all body shapes and sizes to access health services should be considered as important as strategies that facilitate screening and services in other vulnerable and excluded groups. If there is anything that the ASOI can do to support your organisation in this regard, we'd be delighted to meet with you and discuss further. We received an overwhelming positive response from this lead clinical director of this service. And they outlined a proactive approach that they were going to take based on this experience to try and ensure that such a stigmatising and negative encounter does not happen within their particular service again. And although that was a really positive response, the lady with obesity who shared her negative encounter won't go back to that service. And she won't go back to any other service offering that particular procedure because of that harrowing experience. So I thought about her and her experience as the team of health professionals were carrying out a procedure on me. And I thought of how hard it would have been for me sitting there listening to their remarks, their judgmental comments that are not based on fact, that are not based on evidence, and how that would feel if I was living with obesity, to be hearing that said about me. I used the opportunity to help inform and educate the health professionals about obesity. And they seemed to show a lot more understanding and compassion about obesity and those affected by it by the end of my procedure, which actually flew by because I end up talking so much. We can make the most of every opportunity to help inform and educate around obesity. Plant the seed. Those of you in this room, watching online, or watching this back as a recording, Collaborative efforts drive change. So please sow the seeds of knowledge, information, and be part of that positive change, because that will bear the fruit and flowers of tomorrow. And what I mean by that is that by doing that today, in our day-to-day, it will help make our society that we all live, work, and play in a much more inclusive, understanding, and compassionate one. Is mise ní bhartas le meas as an gcuiste ASOI, gur bh míle máil go léir as éiseacht dom. Thank you all so much for listening, and I hope that you enjoy and gain a lot from this event. Thank you.
Thank you, Niamh, for that incredibly powerful opening event. And I hope the campaign that we launched yesterday to highlight the food environment will contribute to a greater understanding of the factors that actually influence obesity most strongly. So I really appreciate that. Our next speaker is Nicola Heslehurst. And actually, the first time I came across Nicola was in Belfast at the UK Congress of Obesity last year. And it was Nicola's opening address where she created this tone of inclusivity, you know, with such ease and fluidity that impressed me. And I said, we have to have her come and speak here in Ireland. So I'm so glad to have you here, Nicola. Nicola is professor at Newcastle University. She holds a National Institute for Health and Care Research Advanced Fellowship exploring the role of adiposity in early pregnancy for risk prediction of obesity-related outcomes. She has a real focus on inequalities in maternal and child obesity and nutrition, in weight stigma during pregnancy, and in the reproductive support needs of women who've had bariatric surgery. Today, she's going to talk about the impact of obesity before, during, and after pregnancy over the life course and the importance of having that health inequalities lens. So, Nicola, you're very welcome.
Thanks, Aileen, and thanks to the organisers of this event for inviting me along to speak today. I don't know, do I need to press something to get my slides up? Or there we go. Thank you. Yes, I'm a Professor of Maternal and Child Nutrition at Newcastle University and also the President of the UK Association for the Study of Obesity. And as always, I was a little bit ambitious with my abstract of what I was going to be able to include in this talk today. So the focus is going to be a little bit more on pregnancy, but really taking a dive into the health inequalities aspect of maternal obesity. So I'm just going to start off by giving an overview of maternal obesity prevalence, health implications, and interventions. And this is a UK focus. So when we look at data historically up to 2017 using the NMPA from England, Scotland and Wales and Niamh from Northern Ireland, we can see that although there are some differences in different countries, around about 1 in 5 to 1 in 4 women start their pregnancy with a BMI of over 30. Unfortunately, we don't have regular data published nationally on maternal obesity prevalence, but more recent data, pre-COVID, 2018 to 2019, showed that in England, prevalence had gone up to 22.3%, so a 1% increase, which translates to thousands of women. So I think this data just shows that maternal obesity isn't slowing down, it isn't reversing, it is continuing to increase. Unless we change something, it will continue to increase over subsequent years. So a lot of numbers on here, but I'll just talk you through what the general message is. So this is looking at anybody who works in obesity will know there's a really strong relationship with deprivation and obesity, and it's no different in pregnancy. Yes, the laser works. So basically anything in bold means it's a significant association. It's all bold. And what we're comparing here is the level of deprivation based on postcode from the least deprived to the most deprived, and how likely women are to be in these different BMI categories based on their level of deprivation. And for all overweight, class 1, 2 and 3 obesity, as the level of deprivation increases, so does the odds of having a BMI in that category. And the highest association here is for class 3 obesity, so the highest level of obesity, BMI of over 40, and the most deprived. And women who are living in the most deprived areas of the UK are more than 3 times as likely to have class 3 obesity. It's a little bit more complicated when we look at ethnic groups, and the data that we have on ethnic groups is not great across the UK. So what we've done here, really similar, anything in bold is significant. Based on the way the data are reported and publicly available, we looked at minoritised ethnic groups together for England, Scotland, Wales and Northern Ireland. And what this showed was any minoritised ethnic groups were more likely to have an overweight BMI or class 1 obesity, but less likely to have class 2 and 3 obesity. We then looked at just England, Scotland and Wales, which had a bit more of a breakdown in their data. And this showed that when we group all minoritised ethnic groups together, what it does is hide and mask what's happening for black women, who are more than twice as likely to have any level of obesity than white women. So it's really important that we don't group heterogeneous populations together, because that could inform policy, it could inform intervention needs. And what we'd see here is that black women are mistakenly being assumed to not have a higher risk of obesity. What this also shows for South Asian women is that there's an increased risk of having overweight or class 1 obesity, but a lower risk of having class 2 and 3 obesity. Now, this is a little bit different to data that we published, surprising myself when I was putting the reference in 12 years ago now, so it's a little bit old data. But we looked at maternal obesity prevalence in England according to ethnic groups over time. And we found that there was a consistent increased prevalence for both black and South Asian women, which is a little bit different to the previous slide. But what we did in this study was for women of South Asian origin, we applied the WHO Asian BMI criteria. And you can see that this is slightly lower than the general population criteria for obesity. And so that might help to explain some of the different patterns that we see in the published data. We explored in this study what happened to prevalence of maternal obesity among South Asian women when we compared using the general population BMI categories with the Asian BMI categories. And the prevalence of maternal obesity doubled for South Asian women. It's really important that we use the right criteria when we're looking at obesity, because again, policy is based on these data, these prevalence data. So using the wrong criteria may suggest that some women are at lower risk than they are. Okay, there's just so much data on what the implications of maternal obesity are to both the mum and child in the short and long term. So this figure was published just this year and I thought gave quite a nice high-level overview, and I'm not going to go into any more detail than this slide. Probably most people who are joining today appreciate that there are some risks associated with maternal obesity. But this figure just shows that there are complications of pregnancy and delivery. Gestational diabetes is a particular high risk for women who are living with obesity in pregnancy. There are also some risks for the baby during pregnancy, and a longer-term risk for both the mum and the baby of developing overweight and obesity and type 2 diabetes and cardiovascular disease. And these increased risks for maternal obesity have led to interventions. Now, others on the programme, the excellent programme today, are going to be talking about interventions. So this is a very high-level overview of what systematic reviews show us to date on interventions in the preconception, pregnancy and postnatal periods. So from the preconception perspective, theoretically, because we know that there are some risks associated with maternal obesity, theoretically this is a really essential stage of the life course to try and intervene, to support women to have healthy pregnancies and to improve those pregnancy outcomes for mum and baby. However, when we look at the intervention evidence base, there's a real gap here. We really don't have good evidence on addressing maternal obesity prior to pregnancy. Nutrition-related interventions tend to be universal interventions, such as folic acid fortification, to try and address congenital anomalies, or they tend to be really specific, so looking at fertility outcomes for a subgroup of the population of women and men who may be having fertility issues. So really, in the preconception period, we have a lack of intervention specific to maternal weight, and this is a real evidence gap. It's a very different picture in pregnancy. We have hundreds and hundreds of interventions in pregnancy. So I guess the key messages from pregnancy interventions are that they tend to be effective at improving maternal behaviours, particularly improved fruit and vegetable consumption, carbohydrates and fat, and improved levels of physical activity. Excuse me. They tend to be effective with maternal weight outcomes, so reducing gestational weight gain and postnatal weight retention. When we look at pregnancy outcomes, the evidence is much more mixed, and we need to really understand and try and use the evidence that we've got from these hundreds of studies to try and understand why we see such mixed evidence. Why do some studies seem to prevent gestational diabetes and others don't, or even make it worse, according to the results of the interventions? There's some evidence to show that when interventions in pregnancy focus on diet only or physical activity only, they are more effective than interventions that try to combine diet and physical activity. There's also some evidence that Mediterranean diet might be particularly... Oh, thank you. Thanks. That the Mediterranean diet might be particularly useful for prevention of gestational diabetes. And so in terms of the evidence gaps for pregnancy interventions, I think the priority is not to repeat more pregnancy interventions for weight management or to try and prevent the adverse pregnancy outcomes, but learn from those interventions to try and maximise the effect. Okay, and then postnatal interventions, which can also be considered an interpregnancy period. So a lot of women will go on to have subsequent pregnancies. So this is also an opportunity to intervene in the preconception period for future pregnancies. And there are fewer studies in the postnatal period than pregnancy, but more than for preconception. So it's somewhere in between. And the focus of postnatal interventions to date is on postnatal weight loss, so much less focus on maybe some of the health outcomes or other measures of maternal and women's health. They tend to focus on specialist teams to deliver the interventions or use technology to deliver interventions, with far fewer interventions embedded into care. And they tend to have a short duration and follow-up period. There are very few postnatal interventions that follow women up, for example, into subsequent pregnancies, and that's a real gap in the current evidence base. But positively, it seems that lower intensity interventions, and those that are more flexible, seem to be more beneficial in the postnatal period. And I think everybody, particularly anybody who's had children, can understand why this might be. Some of the challenges on women's time in the postnatal period might make these interventions, intervention designs much more beneficial and able to engage women. Okay, so the next part of this talk is looking at an emerging health inequality, which is food insecurity, and how that might be relevant for maternal obesity. So food insecurity is rapidly increasing in high-income countries, including the UK. but it's particularly important for women in pregnancy. Nearly 1 in 3 women globally are experiencing moderate or severe food insecurity. More women than men go hungry, and that gap is widening. And there are a range of different drivers for food insecurity that particularly affect women. So women are more likely to be working in low-income jobs, to have poorer working conditions, and also to be main carers within households. There are additional nutritional demands that make the nutritional impact of food insecurity worse for women around menstruation, pregnancy and lactation. And there are some physiological impacts of food insecurity specific to women, including around pregnancy. Now, we don't have any national data in the UK or in Ireland on household food insecurity prevalence in pregnancy. What we do see from data that's been published by the Food Foundation is that households with children are more likely to be experiencing moderate or severe food insecurity. And for anyone who's not familiar with these terms, moderate or severe food insecurity is going hungry, skipping meals, or not eating for a day. So it's much higher in households with children. When we look at households, single adult households with children, more than 1/3 of households in the UK who are single adult households with children are experiencing moderate or severe food insecurity. Single adult households are most likely to be with a woman as the adult in that household. And the closest data that we've got to look at how much this might be impacting in this life course stage around pregnancy is that households with at least 1 child under the age of 4, which includes babies to preschool age, around 1/4 of households in the UK with this demographic are currently experiencing moderate or severe food insecurity. So we conducted a systematic review and meta-analysis to look at what the impact of food insecurity was on maternal weight and diet. And this was published in Obesity Reviews just last month. And what we found was a 53% increased odds of maternal obesity in women that were experiencing food insecurity compared with women that were food secure. Interestingly, we found women with experiencing food insecurity were likely to gain less weight during pregnancy than food-secure women by about 1/2 kilo. And when we looked at excessive or inadequate gestational weight gain, we found no difference for excessive gestational weight gain here, and a slight increase for inadequate gestational weight gain here, so not gaining enough weight according to national guidelines. And this is interesting because we see an increased risk for maternal obesity, and usually alongside that, we see an increased risk of excessive gestational weight gain. So again, this is just a relatively new area that we need to understand a little bit more to know how to best help women with their weight during pregnancy if they're experiencing food insecurity. We also found that food insecurity impacted on diet quality in pregnancy, so reduced vitamin E diet quality measures in fruit and vegetable consumption, and increased the consumption of red but particularly processed meat. We have some more data that's currently under peer review, so it hasn't been published yet. But looking at pregnancy outcomes, our meta-analysis showed an increased risk of food insecure women developing gestational diabetes, having small for gestational age babies, and having increased risk for a range of mental health outcomes, including high stress, mood disorder, depression, and anxiety. Now, this is a talk about maternal obesity, not pregnancy outcomes. However, all of these factors are risk factors for life course health for both mum and baby, or mum or baby, including the risk of obesity development. So we don't know what the current increasing prevalence of food insecurity is going to be over the next 10 to 20 years on maternal and child obesity prevalence. So we don't have any UK data. The studies that were included in those meta-analyses come from North America, from the USA and Canada. And we've just received, or we're in the middle of a study, a food, pregnancy and me study that was being funded by School for Public Health Research, which is across multiple universities in England, maternity services, local authorities, and charities, where we're looking at the prevalence of food insecurity in pregnancy, the impact that has on maternal diet, on pregnancy health, some qualitative work looking at women's experiences of food insecurity and what support they might need, and then the core development of strategic recommendations to try and mitigate the impact of food insecurity in pregnancy. For anybody that's interested in this work, I'm part of an international group that has set up a Nourishing Futures network, a new network to try and bring people together who are interested in food insecurity from preconception to preschool age, for both maternal and child health. Actually, our launching webinar is tomorrow. If anybody wanted to join, you can use a QR code here. This will take you to our website, which has got the launching webinar registration, but also how to join the network as well. Please follow us on Twitter. Still can't get used to calling it X, but Twitter, and you can look at our website. Please do contact us as well if you have any questions about the network. We also have a conference that we're holding in October in Newcastle on this topic, which is really exciting. Abstracts open till 8th of July. Sorry for doing that little plug, Eileen. But yeah, it would be great to see people with diverse backgrounds attending this conference. Okay, and I think Niamh has done a really great introduction to the importance of weight stigma, and this is the last topic that I wanted to talk about today on maternal obesity and weight stigma. I do want to just express some trigger warnings. There is some content in these slides which is highly stigmatising and some people might find upsetting. Okay, so I think probably everybody here knows that obesity is a highly stigmatised condition. It's been described as the last socially acceptable form of prejudice. Weight discrimination is important for anybody who experiences it, but we have data showing that it's 3 times higher in women than men, and it's most prevalent among those under the age of 45, which is essentially women of the childbearing age. So it's really an important area for exploring before, during and after pregnancy. In general society, women's bodies are under constant scrutiny, and during pregnancy this is intensified. There's increased scrutiny, monitoring and control. However, weight stigma in a pregnancy is a really emerging field. There isn't a lot of research that's been done on weight stigma in pregnancy, despite some really emotive lived experience accounts of women who've had negative experiences during pregnancy. The limited evidence that we do have shows that experiencing weight stigma in pregnancy impacts on reproductive healthcare quality, it impacts on mental health, health behaviours and pregnancy outcomes. Now, a fairly small study, around about 500 women in the US, showed that 2/3 of those women reported experiencing weight stigma during or after pregnancy. On average, they experience this between a few times a month and at least once a week, so it's happening on a regular basis. And as you might expect for anybody who's familiar with weight stigma literature, stigma comes from multiple sources. It includes from health professionals and maternity services, as well as from family and friends. But the media was the most frequent source of weight stigma in this study. So I just want to share the results of a review that we did of newspaper media reporting on how newspaper media framed maternal obesity. And this was a review of 442 articles that had some content on maternal obesity in UK national newspapers from 2010 to the time that we did the searches in 2022. The figure here shows the kind of complexity of the data that we found, but the overriding themes were that women living with obesity during pregnancy were blamed for their weight, they were blamed for the risks of pregnancy. This was particularly when newspaper articles were reporting any risks to the baby, and they were blamed for the impact on the NHS, particularly the financial impact for managing their care. Women living with obesity during pregnancy were solely responsible for solving obesity, according to the narrative in these articles, and this was gendered from a school age. and women were a burden to individuals. This included themselves, health professionals, and their children. They were a burden to wider society and a burden to the NHS. And while this was quite complex in terms of the data, at the very heart of these messaging, this narrative, was the oversimplification of obesity being something related to lifestyles and choices. We also looked at the voices that were present. So, up here, we can see the voices that were present in the articles. And really, the lived experience of maternal obesity was missing from these articles. The voices present were organisations or experts, and I'm going to do that when I talk about experts, because some of the voices that were being platformed in these articles were clearly from people who didn't understand obesity. But they were described as experts. They were platformed as being experts. They were the voices of the researchers themselves, who'd conducted the research and were sharing that with the newspapers, and there were the voices of the journalists who were writing the articles. And overall, these narratives were stigmatising. We really looked for positive narratives. We weren't just going in there thinking it's all going to be stigmatising, but it was overwhelmingly stigmatising. So this is where some of the trigger warning content happens. So this, I just want to share some of the quotes from the newspaper articles with you, starting off with the journalist's narrative. So this is where the journalists have read the research or they've read the press releases and they're coming up with their own interpretation of maternal obesity. So pregnant women in Scotland are the third porkiest in the world, with more than half putting their unborn tots at risk by being too fat. Fat mums are risk to tots. Obesity in women as dangerous as terror threat. So we can see how the risk is really the focus here, particularly the risk to the baby. The perspective that women should know the health risks, and if they can't recognise obesity when it's staring them in the face, they shouldn't be having children in the first place. So that control of women's bodies. They will no doubt pass on their bad eating habits, resulting in health problems. That oversimplification of the causes of obesity and the solutions as well. And every woman has a duty to exercise and eat healthily before her pregnancy for her own good and the good of her unborn child. So this is really controlling, monitoring narrative around women and their bodies. So you might think, okay, that's a journalist's voice. They have to sell newspapers, so they're going to go with sensationalist headlines and sensationalist content. When we move to the experts and the researchers who were publishing the research and sharing that with the newspapers, unfortunately, it doesn't get any better. So again, there's lots of data on here, I will share them. Most British women are not fit enough to have kids and need to overhaul their lifestyle before starting a family. That responsibility on women to overhaul their lifestyle. The facts and figures have doubled, or the fact that the figures have doubled is disgraceful, and a real effort must be now put into advising obese women not to conceive in the first place. So again, that control and blame. And that was an expert. A lot of this is caused by people needing to simply overhaul their lifestyle, eating habits, being overweight, and lack of exercise. That real misunderstanding of the causes of obesity. This is the next one's from a researcher who was conducting research into maternal obesity. You wouldn't dream of standing on the starting line of a marathon, having smoked 20 a day for the last couple of years, with a body mass index of 35. You'd try and get all these problems under control before you ran the marathon. Pregnancy is no different. An expert organisation, representing an organisation, said we need to ensure women go into a pregnancy at a proper weight and produce children at a proper weight. So the woman's role in society is to produce a healthy future generation. And this last one is particularly triggering, I find anyway. So the government, from the highest level, the government must rapidly ensure every secondary school girl understands her obligation to stay in shape and look after her health, so that, should she fall pregnant, she enters pregnancy fit. So these are the messages that not only women living with obesity are receiving from the media, but the general population are also receiving these messages. Stigmatising messages in the media cause harm. Media influences the public narrative and discourse around obesity. It influences public support for policy. And unfortunately, I think we've seen very recently with the way that populist policy making is going, it directly influences policy-making decisions. So if we focus consistently on lifestyle and blame and stigma, they're the messages that are going to come across to policymakers. Now, there might be some things that we can do in terms of influencing this, but I think as researchers, we have a responsibility to really consider how we're framing our papers and press releases. How are we writing these? Can a journalist take a section of what we've written and use that to cause stigma? Okay, so I think that's me out of time. The key messages from this talk: maternal obesity is really prevalent. It affects around 1 in 4 women in the UK, and it does impact on life course health for mother and children. In terms of the intervention evidence to base, we've got a real lack of preconception and into pregnancy interventions. Postnatal interventions tend to focus on short-term weight loss. There are some benefits of pregnancy interventions, but really need to unpick that evidence a little bit more to understand why that we see mixed effects on pregnancy outcomes. We see intersectional health inequality drivers of maternal obesity, including deprivation, minoritised ethnic groups, and food insecurity is a rapidly increasing driver. So what will the impact of this be on obesity in the next 10 to 20 years? And finally, weight stigma is pervasive. This includes around pregnancy and specifically in the media. This impacts on maternal health, policy decisions and public perceptions of obesity. And that oversimplification of obesity lifestyles is at the heart of maternal obesity stigma, and how we frame our research is really important to address this. So thank you very much.
Perfect. We have a half an hour for questions at the end for the whole panel. So if you don't mind, we'll hold any questions you have for Nicola for that time. I didn't ask Nicola to leave any space for questions now, so that is perfect. That's perfect. Thank you. Nicola, thank you. Thank you so much for giving us a really interesting and broad-ranging overview. That's exactly the scene setting that we wanted for this morning. And of course, you drew attention to obesity stigmatisation, and that's really important. So we are really delighted to have John Jordan here with us this morning. John is an obesity advocate from Donegal, and of course he's from down the road from where my dad comes from, and we've already had the who do you know conversation this morning. So John is going to share with us kindly his lived experience from childhood right through to adulthood, and in the context of this conference particularly give focus to his journey with his partner when they were starting a family, and how obesity has also impacted on family life as they've gone forward. John, you're so welcome, and we're delighted to have you here for today. Thank you.
Good morning, everyone, and thanks very much to, sincere thanks to Anne for the invitation here, and fellow speakers. It's great to meet everybody today as well too. I just want to say a few words about my personal journey and experiences in the area of obesity and fertility. Yes, as Elena said, my name's John Jordan. I was born in Scotland in October 1966. I moved back to my father's homestead in a small town in Donegal called Ramelton at 8 years of age in 1975. I have 2 younger sisters, born in 71 and 79. Mum and Dad are sadly no longer with us. They passed away in 2009 and 2018. However, I do have an amazing 23-year-old son, Owen, who graduated in actuarial maths from DCU last summer, and thankfully he's now happily enjoying a wonderful career as an actuary with Prudential PGIM in Letterkenny. So that sets a little bit of who I am and what I'm about. Background, I guess like most of you, I went through national and secondary school or primary and secondary school, pretty much enjoying most of the journey, being playfully known though throughout my school life as Big John. As I was always tall and heavy from an early age. And you're okay to laugh at some of the pictures there if you want to as well too, so it just gives a bit of a life journey. I played Gaelic football and basketball at secondary school from 79 to 83, as well as being decent at the shot put and track and field. But I was always the fat guy. And this made me feel very, very self-conscious and insecure in so many ways as a teenager. Even though I got decent grades, was elected head boy by my fellow students, got a good leaving cert, took part in many plays, pantomimes, sports events, quizzes, both at school and my local community. I always felt I had this cloud of what I now know is as obesity hanging over me. I always felt the continuous need to better myself, to push myself, to excel in everything that I did as a way of compensating for my weight and my appearance. And as you can see in some of the pictures, that's showing my past and shows you how heavy I was. I always seemed confident, self-assured, but deep down I was in turmoil, an emotional mess, as I looked upon myself as abnormal and ugly. And in those times, back in the 80s, I guess it's probably the same as it is now as well too for a fella. And I know it sounds very sexist, but for a fella, just any sign of weakness was taken as just unacceptable as well too, and you had to have a stiff upper lip and get on with it type of thing like as well too. So I didn't take the traditional route to uni or third level education, partly because my family couldn't afford it, and partly because I wanted to get away from the small Irish town mentality to see some of the big bad world out there. So in the mid-80s, I went to Toronto in Canada. My Aunt Greta had emigrated there years ago, and when she was younger, and I started to build a life there. But I eventually had to come back to Ireland for my official work visa application. Around that time, there was thousands of people that economically Ireland was in a different position than it was now, and immigration was prevalent throughout, and I was one of the thousands that had travelled away, but I couldn't continue as an illegal alien. It just wasn't acceptable, and if I wanted to continue my life in Canada, I had to come back. So I suppose that gives me the next chapter now. In early 1989, my life changed completely. I had observed an alcohol-free Lent, as a lot of us do in Ireland here as well too. But like lots of Irish fellas, I then went from one extreme to another. Met up with a few friends, went partying for about 3 days as well too. And as I guess at that time, my excuse is that's what you do. Like, so. But we met a bunch of fun, good-looking girls over that period as well too, and as they say here in Ireland, the crack was mighty in the Isle of Man. So everything was great, and this is where I met Mairead. Mairead's on the picture, extreme left of the picture on the right at the top there. That's all her siblings and her family. I met Mairead. She was a secondary school teacher, and folks, I suppose I get a little bit of but she was wonderful. Beautiful in so many ways, great to chat with, lovely company, and boy, did I get butterflies every time I arranged to meet with her or met up with her as well too, and had our first holidays together, went to Cyprus, travelled all throughout, and had a fantastic time. I suppose I have to admit, I simply fell head over heels in love, hook, line and sinker. So they say that behind every good man, there's an even better woman, and I think I'm a living example of that. 1989 definitely proved it for me. I got my Canadian work visa, went back to Toronto, and guess what happened? I was back within 2 weeks. Yeah, that's exactly it. That's what love does to you. But I never looked back, and from then, Mairead, she gave me the confidence and support to go back to uni. So in September 1989, I enrolled as a well, in inverted commas, a mature student in the University of Ulster doing a BSc in Business Studies and Marketing. I graduated with first-class honours in May '93, proposed on holidays in Turkey that summer, and we got married in June 1994. And I can safely say that that was the best day of my life, and all our family and friends were truly happy for us. My work career in sales and marketing started in Northern Ireland, so we moved into our new home in Derry in September '84. Maria had commuted to her work in Donegal. My weight had always been an issue for me, but I guess as a fella I got more leeway, and maybe a little bit of what our previous speakers have spoke about. You can have a little bit more leeway as I was tall and apparently big-boned as a fella. You tend to get away with it a little bit more. I always enjoyed my food, and even though my weight increased, I never let it hold me back from enjoying life, or work, or travelling, or socialising. Yes, I was the guy who always had to get the outsized clothing. As you can see from some of the pictures on the left-hand side, I was the guy who knew all the stores, Mr. Big, High and Mighty stores. I had the 2 and 3XLs, the 58-inch suits, the 50, 48, 50-inch waists. And yes, I was always the guy who enjoyed the buffets and eating out and the socialising side of it. But I now know, with the benefit of counselling and particular CBT over the last 7-8 years, that food was my on button for my pleasure zone, my comfort, my go-to, my blankie, my soother. And the crazy thing about all this is that I could fast for long periods without much food and still work to a very, very high level in managing sales teams, agents, key accounts, and a busy travel schedule throughout Ireland and Britain. My weight always yo-yoed throughout my life, as I tried everything from the ketone diet, Atkins, Weight Watchers, Slimming World, intermittent fasting, the Fast 800 by Dr. Mosley, unfortunately, who passed away there recently, the paleo diet, intense physical gym, the HIIT programs, boxercising, you name it, I've tried it. I'd lose some weight, trim down a bit, then it all crept back again. And it's a never-ending cycle, I felt, of success, failure, success, failure. But through it all, I knew that I loved Mairead and she loved me, and we definitely wanted to start a family as we both felt we were ready for that next stage in our life. What I can say now with the benefit of hindsight is that as a loving couple, you do all in your power to conceive, not to conceive during courtship, thinking that when you start married life, having a baby would be easy peasy. But as we found out, life has many twists and turns. After 18 months trying to conceive naturally, we went to our GP in Derry, and he was very understanding. Mairead went for various tests, and we eventually went down the IVF route through the Royal Victoria Hospital in Belfast. After 4 attempts, the whole process was taking its toll on both of us, especially Mairead with all the hormonal injections and the actual IVF procedure itself each time. It was only after a number of tests, or a number of procedures, that I was tested and found that I had a low sperm count and poor sperm motility. To say this was a shock was an understatement for me. The feelings of uselessness, worthlessness, of failure, and being candid, as less than a man that I always thought that I would be or could be and was. Because fertility is something you certainly take for granted, and this hit me like a ton of bricks. The medics at the Royal Victoria Hospital were excellent in Belfast, and remember, folks, I'm talking about a time now where we're chatting late 90s, 98, 99 here. But they suggested a new procedure called ICSI, which I'd never heard about, probably a lot more prevalent now, intracytoplasmic sperm injection, which we had never heard of at that time. This gave us huge hope again, especially as Mairead was a science teacher, and we were now presented with the prospect that advances in science could actually help us have a family. After so many failures, after so many disappointments, so many soul-searching, tear-filled days and nights, Mairead got the fabulous news in late November '99 that she was pregnant. Needless to say, myself, friends, family were just totally overjoyed, and boy, did we bring in the millennium with a bang. Although Mairead was totally abstained totally, like she was excellent. So Mairead's pregnancy went very well, and Owen was born at 3:05 on Saturday, September the 9th, 2000, and he's literally the proverbial millennium child. But I have to say, I never imagined how physically and mentally draining the past 5 years had been on both of us. The stress, the anxiety, the comments, as I say, from some speakers have mentioned, the comments from family, friends, workmates, the crushing, absolutely crushing feeling of failure, the time involved in all the treatments and all that goes on in between that, the invasive nature and the effect of the hormonal injections and drugs and Mairead, not to mention the financial cost of it all. I immersed myself in work to cope. I was totally unsettled, even after Owen's birth. I changed jobs a few times in the first 18 months to 2 years, as I felt the need to challenge or continually challenge myself, prove myself, given that I couldn't be what I perceived as the man, the husband, the father that I wanted to be. Kept asking myself, how can I be this much of a failure? Feeling out of control, especially when I've been, what I felt at that time, relatively successful in life. Unfortunately, myself and Mairead drifted apart. My inability to cope just got too much for me. It were tough times. I felt that Mairead was better off without me. And even though we had many discussions, I now realise that, yes, I should have sought professional help at that time. But, and it's not an excuse, and I don't want it to seem as an excuse, but those support mechanisms weren't so available back in those days in the late 90s and early 2000s. Mairead went back to Donegal with Owen in 2004. I stayed in Derry, but we always wanted the best for Owen. I mean, he was the wonderful result of our complete love for each other, even though that was the toughest road that either of us had ever travelled. So we were always amicable about time, visiting, and the best interests of Owen at both our hearts. Sadly, though, in 2014, Mairead passed away. She had metastasis of the brain, lungs, and liver after beating breast cancer. And I suppose this huge part of me can't help but feel that the treatments, the hormones, the injections, as well as our own split, contributed hugely to her passing. I started my own business in 2008, but I suffered hugely, both mentally and physically, after I got my type 2 diabetes diagnosis. The hypos, the cellulitis infections, the neuropathic pain, the constant battle with myself to lose weight. It seemed to me that I was being punished even more, as if having fertility issues weren't enough. And in early 2019, I took a serious leg infection that resulted in me contracting sepsis and facing the likely prospect of limb amputation up in the Royal Victoria Hospital again. But thankfully I recovered. But I just felt then that my life was slowly deteriorating, that I was, I don't know if anybody has seen the movie Shawshank Redemption, and two of the characters are out in one of the yards and they're saying, you know, what do you want to do, you know, with the rest of your time when you get out of jail? And one says, well, I'm going to get busy living instead of getting busy dying. So I was the opposite way around. I was getting busy dying at that stage than I was getting living. COVID-19, as you all know here, hit in 2020 and changed our lives completely. But I was determined to do something to the betterment of my health. And this culminated in me having a Roux-en-Y gastric bypass in late January 22 in Letterkenny with a wonderful surgeon called Zsolt Bodnar. And it proved very successful. 2.5 years later, I'm standing here now in front of you. I've dropped from, I think highest weight was probably about 140 kilos. I'm down now to 85. My insulin intake has dropped dramatically from 110 units to 30 a day. And my HbA1c is down to just under 70 at the moment. Like, so they say literally, touch wood, things have been going well for me. The procedures transformed my life. And like so many others who've had the similar surgery, the one regret they have is not having it done 10, 20, even 30 years ago. But we know that's not reality, and that's definitely not the here and now. Scientific knowledge, in the same way that ICSI give us Owen, that scientific knowledge on the side of bariatric surgery and metabolic surgery has advanced hugely over the last even 10 years. So it's fantastic. During this health journey, I also found out, as part of a research study by Professor Carol LaRue at St Vincent's UCD, that I have an obesity gene, an identified obesity gene, and that I have a condition called hypogonadism, which sees me having hormonal issues, especially very low testosterone levels. And as they say, find out that information is every day is a learning day. Last sheet you'll be glad to hear now is conclusions I have down here in learning, and I just wanted everybody to take maybe 10 seconds to themselves, and I'm going to ask you to think quietly. And this is something that came through in my CBT training, and I think it's really, really important. Do you accept yourself? And do you love yourself? Just take a few seconds to think about those statements or those questions, because they are fundamental, what I believe, fundamental to your physical and your mental health going forward as well too. Now, for long periods in my life, I haven't accepted myself or loved myself. And the key reason for that was my weight. How could I control so many things in my life? First class honours, fantastic life partner, wife and mother, business, sales, marketing, dynamic, you name it, could be successful in all those areas of my life, but yet the one that it always come back to was my weight. And the stigma that goes with obesity is enormous. I can't, you know, with Nicola's words are unreal when I'm looking at them there, and I'm saying to myself, yes, it's huge, but, and I'm glad that well, I'm not glad, but I'm sorry, it's obvious that the research results come out and it is worse for women. There is a tolerance maybe of obesity amongst males, but certainly not for females, and it is horrific and it is horrible to see those stories and see those headlines as well too. Like, it doesn't give any credence to the life that person is leading as well too. Thankfully that's changing, that stigma. And I have to come back to, and I'm not plugging Professor LaRue in any shape or form here, but his website was really eye-opening for me. It's notyourfault.ie. It was like a eureka moment when I read the content in that as well too, and that he brought it back to its basic genetic level as well too, to say that so many of these things are outside of your direct control, but there are, science is making advances and there are things that can be done. And doing away with this simplistic mantra that's continually driven towards people living with obesity is just move more and eat less. I flabbergasted at that down through the years as well too, and saying that this is more involved, that I almost had in a bathroom where you have the ball cock situation where it stops the water. I felt at times I didn't have one of those, that I could, if I started eating, I would continually eat. But again, by the same token, I could fast for so long as well too, between meals. Early intervention to tackle obesity issues are vital. Yes, there's no question about that. Yes, education is hugely important, and we need to focus on what we can enjoy eating and not what we can't or shouldn't. There's so many negatives involved with this, and then people get overwhelmed by feeling they have to do so much as well too in this whole process. but especially at the endocrine and hormonal level. That's certainly one thing that I want to emphasize from my few minutes today, is that is hugely important in all this process as well too. It can highlight a lot of possible issues and offer potential solutions as well too. And I have to give sincere thanks to Professor Alex Miraz in Ulster University and Dr. Camis at Letterkenny University Hospital as endocrinologists that have contributed and changed my life dramatically as well too. Mental health support programs need to be an integral part of any fertility journey. And thankfully, I do see that this is being looked at more and more. Remember, again, we were late 90s, and this whole holistic approach to medicine wasn't as prevalent as it is now. I do believe that would have, it's so important that we are encouraged to talk about our feelings to health professionals. I know we should talk as man, wife, partners, whatever, but in this fertility journey, there is a tendency for us to go into our little camps or little protection zones as well too. But talking to health professionals is hugely important in that process to kickstart things. I do believe that would have helped me hugely, as communication is vital, otherwise things fester and they become life-changing, and I'm a living example of that. So, another thing is the need to embrace change is hugely important. It's an integral part of our life journey. I realise that now. And if you think about the evolution of our own species as humans, I mean, if we didn't evolve, where would we be now? We'd still be going around in horses and carts, and we just wouldn't have the life that we have now as well too. They say that the height of management madness is to keep doing the same things over and over and expecting a different result. Well, what I'm going to challenge people today is to think that, well, think about your life in the same way. If you keep doing the same things, if we're in the same channel all the time, we are going to get the same result. And it can be frustrating, very difficult, very hard at times, to embrace change. But that's what I'm saying about the mindset. Do you love yourself? Do you care for yourself? Do you accept yourself? Comes back to that. And I don't want to sound very philosophical or anything about this, but it really has helped me in my journey. And I would have been very thankful for interventions much earlier in the whole fertility process as well too. Change of mindset, change of attitude, change as a sign of strength, both mentally and physically. My gastric bypass journey really emphasised that to me, and having to do an in-depth psychological analysis before I could ever get near any bariatric surgery procedure at all. And the whole area of multidisciplinary teams is something that certainly I think that could be introduced on the whole fertility journey as well too, is that, for me, I said I had to pass a psychological report. I had a couple of meetings with dietitians, a couple of meetings with the endocrinologists, and then 2-3 meetings with the surgeon before any procedure was ever looked at or penciled in at all. That multidisciplinary team approach is very, very important, not only in the bariatric side, but I think on the fertility journey as well too. So, and again, I suppose I'll finish off by saying now, being more topical, the plethora of GLP-1 inhibitors such as Ozempic, Wegovy, and I think now there's new tirzepatide is being mentioned that have become available in the last few years, are fabulous tools to help people on their obesity journey. But they're not magic wands, and they are not silver bullets. I know all the press, and back up with Nicola saying about the press, you see some of these stars and Elon Musk using them and whoever as well too. So, but they're short term, and they don't bring that holistic approach that your multidisciplinary team can to you as well too. Because each of us are individual. Do we accept that our human genome is all different from all the people throughout the world? So why would our medical journey and our hormonal journey, our endocrine journey be any different as well too? They're not quick fixes that many perceive on their obesity journey, but this must start in the mind and be encouraged by positive advocacy from health professionals and yes, other patients with lived-in experience. And it's an excellent approach that I have to say with Aileen and the whole team here to take that, to jump the broomstick, to take that step to involve patient advocates as well too. And I'm not saying that all my journey was pretty. It was all successful. No, it wasn't. I've had the setbacks and the kickbacks as well too. But what I can say is that trying to take control of your health, trying to take control of, well, not necessarily your fertility, but taking control of your health is a hugely important part of this process, which can be helped by professionals like yourselves and taking that holistic approach. The pictures, if anybody wants to have a good laugh, I mean, you can look at it there. And I look at it myself now, and I'm taken aback at times. So you wouldn't believe how many people that I have met over the last year or so that don't recognise me, that I'm not the person, and they always think that I had cancer, or I was sick, or something really bad happened to me, or whatever. But no, it didn't. So, and as I say, the fruits of our life journey, you can see there, no one. So yeah, it's. As they say in some of the movies, it's been emotional, and thank you very much for listening to me and taking the time to get involved in this whole process. Thank you. Thank you.
An absolute heartfelt thanks to John for, I suppose, bringing our conference from the domain of the academic and the abstract into a deep understanding and an insight into your personal experience. I really appreciate that. We have gone over, but I also know from my own lived experience that you never stop a Donegal man mid-story. So I do apologise for that. We might have to just shift things a little bit when we come to the coffee break, so just bear with us on that, particularly to our online audience. But I think it was certainly worth listening to John's whole and complete story, so thank you. Our next speaker is Dr. Rosie Dawson. Rosie is a consultant midwife at the James Cook Hospital in the northeast of England. She has about 20 years' experience working in both clinical settings and in academia. She has a special interest in public health and lifestyle and midwifery-led care. At the moment, she's working in partnership with the NHS, community organisations and charities, and has co-designed and piloted the LIFT programme. And LIFT stands for Lifestyle, Intervention, Fertility and Togetherness. And she's going to tell us a little bit about how all of that works. So thank you, Rosie.
Just take my glasses on and off. Good morning, everybody. My name's Rosie, thank you for lovely introductions, and it's been really nice actually listening to the other speakers before I've come on to speak this morning, listening to John and Nicola, because actually, as I've started to listen to other people, I've thought, actually, I'm going to say that and I'm going to say that. So it's quite nice and reassuring that we're hopefully all kind of talking from the same hymn sheet. I have recently just finished my doctorate in public health at Teesside Uni. And for lots of you, I'm sure you'll appreciate that was a long and challenging road. So it's been lovely to actually come to this point where I'm able to stand and talk about kind of what I've done and what we've found within that. And I hope that that is just the beginning of my journey with kind of within this field. I have been a midwife for about 25 years. I'm a fit and healthy individual. I enjoy exercise. I have no lived experience of infertility, and I've no lived experience of obesity. I'm lucky enough to have 2 children, and I've had 2 children without any complications, although we were laughing this morning at some of our chats with kind of toddlers and teenagers, and always without complications, but without complications of the conception, I would like to say. I've always had quite an interest in lifestyle and how it affects pregnancy particularly, and exercise and obesity. Throughout my career, I have had the pleasure, I'll put it on at my first slide, I have had the pleasure of working with women and birthing people, usually through a lovely journey of having a baby, becoming pregnant, and then the birth of a child, and occasionally sometimes that ending in the tragic bereavement of a child as well. So I have a definitely varied job kind of from day to day generally. For all of those people that I have worked with and looked after, apologies, I'm a bit sniffly this morning, I'm grateful and honoured for all of the experiences that I've gained with those people. I always realised that couples who had been through the journey of infertility had a longer journey to get to that point. And as a midwife, they're always kind of described as couples or babies who are a bit more precious because they've been through that journey of infertility. And if I'm honest, before I started doing all this work, I kind of thought, well, why are those babies any more precious than any other babies? Because actually, surely all babies are precious. I started working, I went from being a midwife in the NHS and then started working as an academic at the university. And I saw this opportunity to work on the project, the LIFT project, kind of bring all of my interests together, my research and my passion for making a difference, hopefully. And that came the LIFT project, which I'm going to talk to you about today. I do want to emphasise that I'll refer to the participants and the people that I talk about as women, because the women that we recruited refer to themselves as women. But I know that infertility can affect anyone, regardless of gender, identified gender, or sexual status. Infertility in itself is complex, and obesity is complex. And I think lots of the things we've spoken about today tell us why those are complex. But actually, when those two things are combined, they multiply in an interlinking tangle of emotions, medical complications, limitations and barriers, and lots of other things that overlap those, particularly around stigma, societal expectations, and psychological health are affected in a sort of tangle of all of those things. We know that lots of previous interventions have focused particularly on pregnancy outcomes and on weight loss particularly, and looked at what we would describe as quantitative outcomes for people who are suffering from infertility and from obesity. But what I've found, particularly in looking at this research, is there isn't an awful lot out there that looks at things from that biopsychosocial, the holistic that John mentioned, and actually looking at the impact on the person, the human being, of these interlinking conditions. So the LIFT project itself was co-designed to try and improve well-being for women who were suffering from obesity and infertility. And we used an evaluation research pathway. The LIFT worked together to co-design an intervention with lots of stakeholders. We worked with women who had experienced infertility. We worked with our local reproductive centre, and we worked with deliverers and researchers. Oh, thank you. She's brought me a hanky for my sniffling nose. So better to do this away from the mic. Thank you. I'll try and reassure everybody on the plane on the way back that I haven't got COVID, won't I? Yeah, so we worked with lots of different people to form a steering group, and the steering group itself aimed to co-design the intervention and look at different aspects of what we wanted to be in the intervention. So as part of the co-design, we undertook some focus groups with women who had been through the experience and journey of infertility. Those women were at different points of their infertility journey, so we tried to have focus groups that got different experiences, as in couples whose infertility had been successful, people who were still amidst that journey, and people whose infertility hadn't been successful and had perhaps gone down other paths or had decided not to have children. Women spoke very much around the physical and emotional pain that they experienced with infertility. Some of them even spoke about real resentment and hate that they had for people that they loved that had become pregnant. One girl particularly spoke about how much she loved her sister, but when she announced that she was pregnant, she was so upset and she hated her so much, and that really upset. For someone that you're supposed to love, she actually really hated her at that point because she was pregnant. And for that, it was really difficult sometimes to listen to women talk about blame, guilt, and overwhelming sadness. And often alongside that went depression, anxiety, and low self-esteem. Some of the quotes from the women: "It's hard to motivate when you're hurting so much, and it takes over every thought in my head. It's awful. I just want a baby so much, and I feel like I'm letting him down. I'm not a real woman, and it's all my fault. Every night I have the same dream, walking down the seafront pushing a pram, and I grieve every day for what I planned. The blame and guilt just takes over." When we talked to the women about the project and kind of the initial ideas of what we had planned, they seemed really pleased about it. They said, "Well, I wish that had been around when I've been going through the journey." Some of the things that they said was, "I just wanted to feel better and stronger and happier and prepared for the journey, regardless of what the outcome would be. Just being able to talk to people and realising that I'm not alone and it's not my fault and I can be happy regardless." Current practice within our reproductive centres in the UK is to recommend weight loss for any woman with a BMI over 30 before they're given infertility treatment and before it's offered. And it is recommended by the infertility services that treatment isn't offered to those with a raised BMI and a BMI over 30. We worked with the local fertility centre in the northeast of England, and they said that actually lots of couples were declined fertility treatment on this basis alone, without any other assessment, just on the basis of the BMI. Those recommendations themselves often perpetuate feelings of blame and guilt, and for those people there was no recommended pathway. The women of our catchment area that we looked at were given another appointment, usually in 12 months' time, to come back to the fertility centre. Now, that isn't recommended practice, and actually it was just something that centre did. Often in other centres in the UK, they're just told to go off and lose weight and come back when you've got a BMI under 30. But they were given an appointment 12 months later to come back with no support, no signposting, just asked to go off and lose weight. And often they found that they returned actually having gained more weight, usually within that 12 months, but also often with declining mental health in amongst all of that. And given, I think, what we know about the epigenetics and with maternal mental health and what effect declining maternal mental health has on the unborn child, it seemed really short-sighted that our guidelines were so medicalised and based on such an arbitrary numerical cut-off. So this is us advertising the LIFT project, and LIFT stands for Lifestyle Intervention, Fertility and Togetherness. Now that sounds like quite a mouthful. Initially, the project was called Fit for Baby, which actually is a bit more catchy, isn't it, when you think about marketing purposes. But when we spoke to the voices of the women and those that had experienced infertility, they felt like actually that just perpetuates the blame even more. Like, I'm not fit for a baby, I'm not fit to have a baby, and I'm not fit to be a mother. So they felt like that just perpetuated that pressure that was on them a little bit more. So we changed the name, and they chose the name as LIFT, because they wanted to emphasise that they would be lifting each other up within the group, and that there would be a real focus on that peer support and togetherness. The project was done in conjunction with Tees Valley Sport, Teesside University, and it was funded by Sport England. And the initial aim of the project was to increase physical activity to be able to increase pregnancy rates. But as I've already touched on, and as obviously we've touched on this morning, the voices of the women that we spoke to said actually if we continue to focus on what we struggle with most, that's actually not going to be helpful at all. In fact, it's almost going to be counterproductive if we continue to focus on that. And what they said they wanted was support to improve their well-being, their self-esteem and their confidence in order so that they could actually begin to tackle some of the compounding factors of that tangle of obesity and infertility. So therefore we changed the aim of the project completely got around that funding a little bit and said we were still going to look at some of the physical activity, but we would change the aim to say that we wanted to actually improve the women's well-being and not just have those parameters that would make them deserving of treatment, but actually focus on the person as a whole and the women as a whole. We did a programme that was over 12 weeks of activities. We really wanted to focus much more on holistic health rather than it just being an exercise programme or a physical activity programme. But we also took into consideration the benefits of exercise as well in amongst that whole programme. So we looked at exercise, we had some nutrition, we had lots of support in amongst that, and mindfulness as well in amongst all of our intervention. We recruited 8 participants, all of which were in one group, and all of those women had a history of infertility and a BMI over 30. This is one of our activities that we did, outdoor swimming. For anybody that's been to any lake in the northeast of England, not quite as cold as Scotland, but probably as similarly as cold as it is here in Dublin. This was one of the activities that they particularly enjoyed, was the outdoor swimming. The guy that actually did the outdoor swimming was a fantastic guy that actually did this in his spare time, but also worked as a learning support needs teacher. So he was really focused on, as well as the actual swimming activity, he did some kind of mindfulness and meditation when the women were in the water. You can see from this picture that there are men in the water as well. Some of the partners joined us for this activity. It was something that we spoke quite a lot about within the steering group, within the focus groups, was do we just do this for the women or do we include their partners as well? There was quite mixed views on how we should tackle that and whether this intervention should be just for women, should be for partners, for both. How do we tackle that? Some of the women felt that they wanted the support of the partners at the activities, but lots of the women said that they wanted to be able to talk to women that were in the same position. They felt like physically and emotionally they went through a different process than their partners, and they felt as if they would open up more if they were in a situation with other women. One of the women in the focus groups, although did particularly say that she didn't want to do anything with anybody else's partner there if she was showing her wobbly bits or wearing lycra. I'm not sure whether she meant their own or their people's partners, but that was something that they talked about, that they would feel more vulnerable in some of the activity situations. We decided that it was going to be on an activity basis, so we talked to the women in the intervention, and they decided that it's some of the activities, like the open water swimming, that it would be suitable for the partners to be there, but lots of the activities where they were going to be doing lots of peer support and talking to one another about their experiences, then they wouldn't invite the partners to that. We did have lots of online activities and other things that they could do with their partners at home if they wanted to be involved in that. This is one of the cookery sessions that we did. We had a venue that we used that was like an old home economics style studio where they could do cookery and share recipes, and this was supported by a local community trust called Little Sprouts. So they did recipes, they did some education, they talked about meal prep and tips for kind of being organised with meal prep and healthy swaps as well in amongst that. We worked with lots of local partners and community and charity organisations. We did walk and talk sessions, we did dancing, Pilates, mindfulness and running. It was really important to us that we kind of used what was already being done. For many of us, there's lots of excellent things going on already in the community, and what we didn't feel that we needed to do was reinvent the wheel. But actually, for lots of it, it was just about bringing these things together. It also meant that after the 12 weeks, that we didn't just say to the women and their families, right, your 12 weeks is finished, off you go, and they went back perhaps into the lifestyle that they'd been in before, that they actually might find an activity that they really particularly enjoyed and continue doing that. And because it was local partners, it was more easily accessible for them. It also meant that, probably more personally for me, that the money that we got from Sport England, didn't just go to one big local corporation. It went to actually the local charities that were already doing a really, really good job so that they could continue the work that they were doing. The peer support was provided every session by a charity called Red Balloons, and Red Balloons were fantastic. There was 2 of them that came to every session, and they provided peer support and kind of facilitated the women talking to one another. But they also ensured that there was 2 of them at every session, so that if any of the women had a particularly bad week and if they wanted to have a one-to-one chat, that they could take them off and be able to have that chat in amongst there. So it meant that they had that option in between there. So it was really good that we did that. We had indoor and outdoor activities. As I mentioned, we used the Live Well Centre, which has a cookery set area, it has a studio, but we used some of the local parks as well, and we used the local authority gym as well. So that, again, it was something that, with the support of the other women in the group, they could try for the first time, but then perhaps be able to go and do that again if they wanted to afterwards. It was supported also by a website. We had group chats, activities, and we also had some recorded sessions on those websites. So for the mindfulness, we'd recorded some scripts that the women could go back to and listen to, and the partners and the families if they wanted to. We had lots of other things within that helped each other. What was really nice as well, actually, is that we listened to lots of the participants within each of the sessions, because we wanted to make sure that it was there for them. There was no point in us putting all of these things in place and on a website if it wasn't any use to them. So we asked them what they wanted on the website as well as that. So a couple of examples of that where they talked at one of the sessions about how finance had been a problem, how fertility treatment, and I think John touched on it as well, that fertility treatment is expensive, how the actual treatment had affected them, and for some of them that they had to be off work for a period of time, they'd had to take leave and unpaid leave, so how finance has affected them. So we put some things on our website around about assistance with finance and kind of how to budget things within your fertility treatment. Another thing that they mentioned within these groups is that for a few of these women, they had achieved pregnancy, but they had ended in miscarriage. And we also put some signposting on there to things, charities like SANS, and some signposting for bereavement support as well within there. So we listened to what the women were experiencing, and we provided that on the website. And there was other things that some of the women had said, oh, I've used such and such an app and I found that really helpful. So we put those on and shared those as well. So, thinking about collecting the data, as I've already mentioned, we really wanted to make sure that we weren't just measuring the success by a quantitative measure alone and measuring weight and BMI. We knew that for lots of reasons this had already been done, but we really wanted to ensure we were taking in that whole biopsychosocial, holistic within the design, but also within the measurements to see if we had made any difference. Because, as I mentioned, we were funded by Sport England, we had a bit of a limitation of measuring weight and BMI. So we did measure weight and BMI at the beginning, at the end of the intervention. But we wanted to make sure it wasn't just that we were measuring, and that wasn't just our focus. So to give more depth to the data we collected, we performed interviews at the beginning and at the end of the interventions, and we also did a wellbeing questionnaire. And we did that again at the beginning and at the end of the intervention. It was really important that we captured not only the group changes, but that individual journey. It was a small group, so our aim obviously wasn't to make assumptions about the population in general, but just to give us a bit of an insight into what difference an intervention of this type could make to these women and to this population. So, did we make a difference to the Women of the Lift project? So the total group weight loss was 16 kilos. An average weight loss was 2.2 kilos. But the women said they felt physically better, and they had an average increase of 12.2% on the physical functioning. They all said that they had more energy. Some noted that they had improved sleep, and many reported that they had increased motivation and vigour. There was an average increase in energy of 19%. And social functioning, which was a really important aspect of the interview data and dominated the interview data, they had an average increase of 20% in their social functioning. and peer support was quoted to have a significant impact on that. They had a marked improvement in emotional well-being, with an average increase in 13%. Some of the quotes from the interviews were, "It really helped to share and listen to others, somewhere I can talk to other women, and I can listen and know that I'm not alone. It's just processing it all. It helps me prepare and cope. It gave me a focus and made me feel motivated to change. I feel like I'm sleeping better and I have more energy." So what does that mean for us, for services, for women, for families and their partners? Well, the lift itself appeared to have a positive impact on the women's social functioning, their energy, their physical health and their emotional well-being. Future policy needs to consider the impact of individualised factors, and not to mention the importance of peer support for this population. We need to start to consider that biosocial impact and the holistic factors that surround well-being, and develop guidelines which reflect infertility and preconception care that considers the whole person in an intervention. We need to embed this into our services and not simply expect that women suffering with obesity should lose weight short term to achieve pregnancy or be deserving of fertility treatment. During this research, I've learned so much about my own capabilities, my own professional practice as a midwife, and of course the journey that women and birthing people often embark on to become parents. I have a newfound admiration and respect for anybody that has been through the emotional anguish and roller coaster that is the journey of infertility. And I think now I finally do understand why those babies are so precious, a gift that many of us take for granted, probably including myself. Enough about me. What happened to the lift women? So we finished in January 2023. Since then, we've had 3 babies. One of the ladies has got married and is undergoing infertility treatment. 2 of the ladies have joined the local gym and have continued to go there together. 2 have continued to do open water swimming every day, through the colder days, I think, as well. One has actually set up a local walk and talk service for partners and women who have suffered from infertility and obesity. So she's continued the great work of the LIFT project through that. We should never underestimate the power of peer support, listening and motivating others. The LIFT project has emphasised and shined a light on the problems that link obesity and infertility. But maybe the solution doesn't have to be quite as complex. By improving well-being, this may be the key to making a difference to this population. And I just want to leave you with a little quote. We shared a book around the group about infertility, and it was a novel. It was a story about a couple that had been through infertility. And as the intervention finished, 2 of the women went and got a tattoo with a quote from the book on their tattoo. And their tattoo reads, "If you only shine a light on your flaws, all of your perfects will dim." Thank you. I'll take my smelty hanky.
Thank you, Rosie. Thank you so much, Rosie. It's really nice to see the programme as a vehicle to continued improvement and even the setup of other services by the women themselves. So that's really, really powerful. We are due a coffee break, you'll be glad to hear. We're running a little bit late, so I'm going to reduce the coffee break, if you don't mind, 15 minutes. I think you can take your coffee cups back up here, is that right? No, blank stares down below. But 15 minutes, so it's starting at 22 and we'll be back at 5:02, and we'll try to pull back a little bit of time later on as well around the Q&A. So enjoy your coffee, and we will see you back here for those who are online. Thank you. Folks, you're very welcome back after the break. And our next speaker is Sharleen O'Reilly. Professor Sharleen O'Reilly is an associate professor at UCD. She's also a registered dietitian. I know her well from our work together on the Nutrition Society Committee here at the Irish section. She centres her research on non-communicable diseases, disease prevention for better maternal and child health. And she's also on the executive committee of the European Federation of Association of Dietitians, as well as the International Federation of Gynecology and Obstetrics Committee on the impact of pregnancy on long-term health. So today she's going to be speaking to us about behaviour change for healthy weight management during pregnancy and beyond. Thank you, Sharleen.
I'm delighted to be here talking about nudging new habits, and I'm going to cover several areas. So I'll just start here. So in terms of the focus of the talk, I want you to just look at the picture in terms of when we envisage a woman in pregnancy, we think about it as a window of opportunity. And as you can see in this case, the mother is clearly contemplating what she has in store for her. And we know that women at this time are actually highly receptive to health messages. We also know that they're in high contact with health services. And as a result, we've got a real opportunity to influence the intergenerational health of not only the mother, but also of her child. And so as a result of that, I'm going to kind of be looking in that window over the course of this talk. So Nicola set the scene really nicely around obesity and overweight being a growing problem within pregnancy. And here in Ireland, 1 in 2 pregnancies, so that's half of women experiencing pregnancy, have either overweight or obesity. And so as a result, we know that there are groups that are at increased risk, as Nicola mentioned, in terms of those from different ethnic minorities and also different races. But we can also see that because our population is gradually gaining weight over a life course, as a woman ages, she's also more likely to experience a pregnancy in the categories that are overweight or obesity. So bearing in mind the complications that Nicola already highlighted, the things that I'm actually going to focus on are the longer term repercussions of living with obesity and having a pregnancy in that period. So those with the pink arrows, so cardiovascular disease and type 2 diabetes, are long-term associations with somebody who has experienced a pregnancy in that higher BMI category. Also, you'll note down the bottom, there's a lower incidence of breastfeeding in women who have a high BMI. So as a result, that can have future health implications for the mother and also for her infant. And so these first 1,000 days in and around pregnancy and the first 2 years after delivery are really key developmental periods for a woman. So there's been some really nice evidence that's been accrued in terms of bringing the perspectives of a woman into this area of research. And what we know is that there's a lack of support for women during pregnancy that are living with obesity. So this recent work by Julie Abayomi's research group out in Liverpool found that 4 key themes were present within her interviews with women, and that they experienced inconsistent antenatal care. They also knew that they needed additional support, and they commonly cited things like the media as being something telling them that they were at risk, and that ties in with your findings in terms of the stigmatizing language. The women felt judged about their weight in terms of their health, but also how they were going to need to interact with the health service, and that weight cycling was highly prevalent in this population and brought with it its own challenges with respect to how a woman engages with her health during pregnancy. So one way of providing support is preparing clinical practice guidelines. And in 2022, the ASOI was fortunate in redesigning the clinical practice guidelines that were developed in Canada for Ireland. And I was invited alongside Professor Fionnuala McAuliffe to redesign the chapter on weight management for women during their reproductive years. Now, I'm not expecting you to read the guidance that's there, but one of the key areas was noting that behavioural support should be provided, and that diet, physical activity and breastfeeding were all areas that were going to require particular support. So in looking into that window of opportunity, one of the things that we know that we should be doing is providing additional support. So how do we actually do that? And one of the key things we can do is look to the literature and see what would be the best way potentially to support the woman at the right time, at the right place, and with the right care that suits that woman. And because we know that health services are not nimble by nature, we need to think about what is actually a flexible way of potentially providing evidence-based support. mHealth technology, as you can see in the picture, is a widely available, flexible and relatively dynamic service that potentially can be used for health for the woman. It's also something that hangs around in the back pocket or the handbag of most women, and they are actually high users of this technology. So it means that it is something that potentially has scalability. So we did some extensive analysis of the literature. We did a qualitative meta-synthesis after looking at whether or not women actually valued health interventions. And the groups that we looked at in particular were those that had either gestational diabetes, overweight or obesity, or both conditions. And we found that there was 29 studies out there from inception to this year, and there were 604 women included in that. Now, it might not sound like a lot, but for qualitative data, that's quite a lot of opinions, and it was across mostly westernised societies that we had these findings. And what did we find? Well, women on the whole were supportive and felt positive that mHealth was something that they wanted to and did use as an intervention. They felt that it acted as a support and as a personalisable tool. They could see it having an important role in helping them to self-monitor, to motivate them, to provide peer support, and also to give information that they could trust. They also found, in terms of it as a personalisable tool, that it was a better way to have some levels of communication with the health services. They found it was adaptable to their needs and that it was convenient. But there were some technical issues that needed to be considered with the technology. So if you're delivering it in a remote community or areas where connectivity was an issue, then these needed to be really thought about. So taking that learning, we developed up the Bump to Baby and Me study. So this was a randomised controlled trial across 4 countries, Ireland, England, Spain and Australia. And what we looked to do was an intervention that could think about implementation from the very start. So typically when you see trials being designed, they're quite complicated because they need to have a really controlled environment. But what we wanted to do was take a way of identifying the women that could potentially be scaled up within a health service. So we used a screening tool that collected normal data that was in the first antenatal visit across all countries. And women were risk scored. So if they scored 3 or higher, they were at a 30 to 40% increased risk of developing gestational diabetes. And they were invited to participate in the study. The study provided them with either intervention, which was usual care, plus an mHealth application with a real health coach that was supported within the app, and or usual care, which was the control arm. The intervention occurred from early pregnancy right the way through till the mum had a 1-year-old baby. And so that meant it was quite unusual in the duration. So we had 18 months of an intervention. And for anybody who's ever taken part or run an intervention, that's a really long time. So the intervention itself was provided through asynchronous, so that's out of sync with time, contact with the mother, as well as synchronous communication. So there was live video chat with the mothers at set time points. There were 2 main time points. The first initial visit when the woman was in early pregnancy, and then there was one when the mum was actually postpartum. So around about 8 weeks postpartum was when she had another touch base for resetting her targets, her goals, what she was actually looking to do. And it was very much driven by the mother's desires in terms of the health goals that she set. So we were quite holistic in our approach. So what was the intervention? Well, Leva Healthcare is a provider of an app that can be modified to suit the needs of the individual intervention. And what you can see here is just a screenshot of their homepage. So we had the app. It also had the capacity to support a woman around goal setting and other aspects of monitoring different aspects of her health. And we developed up bespoke resources that were available within the app, but were also integrated into the health coaching for the mother to ensure that they were getting messages that were suitable, evidence-based, etc. So the resources we had were around diet, physical activity, stress management, sleep, breastfeeding, navigating health systems. So they were quite spread out right the way across pregnancy and beyond. So while I don't have final outcome data to share with you yet, sorry, I do have some preliminary data. So obviously this may change, so just bear in mind, it's probably best not to take a picture in case the numbers do change. But what I could tell you is that as far as an intervention goes, we found that 1 in 2 roughly women, when we screened for them in normal routine care, were eligible to take part. So that meant we had quite a high risk population out there, naturally. And when we invited those women to take part, half of them again said yes to the intervention, which was a really positive finding. So there was a definite interest in our population to taking part. When you look over to the right, there's data in terms of retention. So we retained 70% of the women across the 18 months, which I think is no mean feat and actually speaks to the value the women were getting from taking part in the study. So what were our baseline population like? Well, you can see that we predominantly had a Caucasian population, although Australia was much more ethnically mixed. We mostly full-time employment and higher level educated, again aligns with most randomised controlled trials, in married or de facto relationships. But what we did note was that poor sleep was reported by a lot of the women. And particularly we found things like elevated depressive symptomology was higher than we had expected to find in this group. And when we looked at an analysis of variance, what we found is that participant age, activity levels, and sleep quality were predictive of their BMIs. So I think one of the things that we've even taken away from just this initial baseline analysis is that sleep is something that we often miss within lifestyle, inverted commas, interventions. And it's something that's actually quite a strong determinant of health. So it's perhaps something that needs greater attention going forward. And we were glad that it was a component within our intervention. So we'll see what's going to happen going forward. We didn't just assess what was going on in the intervention. We actually looked at factors that were in and around the intervention to check for implementability. And we also looked at the wider context to see were there aspects that potentially were going to influence an intervention if it was rolled out. So we'll also be publishing data on this, and we'll be having an implementation toolkit as a result of the project and implementation workshops early on next year. So definitely consider that an invite if you're interested. So while Bump to Baby and Me did have breastfeeding support built into both the antenatal and postpartum periods, we also are interested in the fact that, if you're not aware, Northern Ireland and Ireland itself have some of the lowest breastfeeding rates in the world. And particularly we know that women who have higher BMIs are more at risk of not having the breastfeeding journey that they would like. So we wanted to explore, could we actually improve breastfeeding outcomes for women living with overweight or obesity? So to lead up to designing an RCT, we did some qualitative work. And what we did was we interviewed women who had high BMIs, who had successfully breastfed for 6 months or more. We interviewed partners, and we also interviewed healthcare professionals. And then we overlaid that on a health behaviour change framework, the COM-B framework. And what we found were that there were 3 key factors that influenced a successful journey for a woman. And that was knowledge, self-efficacy, and support. So based on these things, we decided to apply them into a study which became the Latched On study, which was led out by the National Maternity Hospital and also the Ireland East Hospital Group. And we had 4 hospitals engaged in the study. We had 225 women participate from early pregnancy right the way through to 6 months postpartum. And we did the intervention with the intention of crossing the entire breastfeeding continuum. So you can see there we started with antenatal education, where we invited the partner for peer support. We also redesigned the antenatal breastfeeding education to have positive images of women with higher BMIs breastfeeding successfully. We had quotes from the interviews that I mentioned just there a second ago to bring the lived experience of the woman into the education. The woman received immediate postnatal support as well as medium-term support. And so we looked to see whether or not there would be an outcome at 3 months and 6 months in breastfeeding outcomes. Now, what you can see up here is the findings from the study. Now, you'll note that our primary outcome was at 3 months, and we didn't find a statistically significant difference between groups. We did see that the antenatal group that experienced the redesigned education were more motivated and had positive attitudes towards breastfeeding. But in terms of outcomes, we didn't see a difference. And you might think, well, that's a bit of a shame. But actually, I was delighted to see the outcomes that we had. We had breastfeeding initiation rates that Scandinavian countries and countries like Australia would be delighted to have. We had nearly 98% of women starting to breastfeed. And we also had continued success in their journeys. So what we did was we looked at the control group to see were there any factors there that might have influenced their success as much as the group that were the intervention group. And what we found was they accessed more private lactation support. And to us, what that meant was that maybe participating in a study that was about whether or not a woman wanted to breastfeed or not was sufficient enough to help prime her self-efficacy around wanting to breastfeed and finding solutions through her own networks and navigating that challenge. So what we know is that providing adequate education and support to women who want to breastfeed is really important, and you can get the results out at the other end if you put in that effort. So I currently have a PhD student on Bump to Baby and Me, who's a lactation consultant, Liz McGowan, and she's looking at breastfeeding self-efficacy and whether or not there's changes that occur in the antenatal period as opposed to postpartum that potentially help determine a woman's success. So more coming out of there soon. So you might be asking, well, we're looking into this window of opportunity. What can we actually do now? We don't want to wait for the results of these kinds of studies. What might be available to us to intervene to perhaps support a woman to have a more successful journey? And what we can see is, it was mentioned at the start by Aileen that FIGO, the International Federation for Obstetrics and Gynecology, is something that I've been involved with Fionnuala McAuliffe here in the room. And what the committee has been working on is a pregnancy passport. So this is a piece of paper, it's A4, it's folded in half, and it provides the woman with her own data in relation to factors that we know increase her risk for chronic disease, in particular cardiovascular disease. But it's a way of giving the mum the agency and the advocacy to bring her own health information into conversations going forward outside of the secondary or tertiary maternity services. So it's seen as a communication tool, it's evidence-based, and it might help bridge that gap that we know exists between maternity services and primary care. And as you can see there, being at your best body weight and breastfeeding for as long as possible are some of the key messages that are highlighted to the mother. Down the bottom, you can see that there's a link to the FIGO nutrition checklist, which is also another evidence-based tool that's available for use. It's got 11 languages, and it's there to support women to engage in conversations around nutrition in a way that's framed around dietary patterns and definitely motivating towards health. So what are my take-home messages? Well, firstly, the thing I'd like for you to take away is that overweight and obesity is an increasingly challenging problem for both women and the health services. and that health behaviour change needs to be considered when we're thinking about implementation. It needs to be the right care at the right place, whether that's virtual or physical, and at the right time for the woman. And that our solutions need to take a wider implementation approach towards preventing future non-communicable diseases like type 2 diabetes and heart disease if we want to improve things going forward. So I'd like to acknowledge my fabulous collaborators, as well as those that have funded this research that I've presented here today. And thank you very much for listening.
Thanks, Mel and Sharleen. We'll hold questions for the Q&A session, so Sharleen will be back with us shortly, and you can ask her the burning questions that I'm sure you have now about the intervention. Our next speaker is Michelle McKinley. Michelle and I were PhD students together more years ago than we'd care to remember in UU, and now she's professor at the Centre for Public Health at Queen's. Her research centres on the ability of dietary interventions to modify nutritional status and risk of chronic disease, including diabetes and heart disease. And she also works to explore novel approaches to encouraging, supporting diets and lifestyle behaviour change and weight management throughout the life course. At the moment, her real focus is on women's health, and this includes developing and evaluating complex interventions before, during and after pregnancy. So today, Michelle is going to tell us about the SMS, or Supporting Mums programme, and what about the acceptability and scalable aspects of that. So really welcome you here, Michelle, and thank you.
Thank you very much, Aileen, for that introduction, and thank you to Safefood for the invitation to come and present to you today. I've really enjoyed all of the presentations so far, and now we're shifting to the postpartum period. So let me just move along to my slides. So for the next 20 minutes or so, I'd like to tell you a little bit about some work that we started 10 years ago, which does not seem possible. And Nicola was saying that about one of her papers from earlier, but it does not seem possible that we started this 10 years ago. And the focus of that work was around trying to find acceptable and scalable support for weight management after pregnancy. And this is the Supporting Mums intervention. I'm not going to labour the background too much because the context has been very well set by all the previous speakers, but we know that pregnancy can set women on an upward trajectory when it comes to weight for the decades ahead. And about 1 in 4 women will have substantial postpartum weight retention at 1 year. So that's about 1 in 4 women who will retain about 4 to 5 kilograms of the weight that they have gained during pregnancy. When you look into the extended postpartum period, so in this study they have focused on between 1 and 2 years postpartum, what you see is that a proportion of women will gain weight during this period. So in this study, about 1 in 4 women gained just over 2.25 kilograms between 1 to 2 years postpartum. And this extended postpartum period, or late postpartum period, is really important. It's the interpregnancy period. It's the period where women are preparing for the next pregnancy. So we have, the complexity of perhaps, gaining excess weight in pregnancy, not losing all the weight that you gain in pregnancy, and then perhaps gaining more weight during the postpartum period. So there are certainly opportunities for weight loss in the postpartum period, and we know that the postpartum period is that interpregnancy period. It is the preconception period for subsequent pregnancies. Women often have new motivations around health based on their experiences of pregnancy and having a baby, and there's the potential to influence the mother's health, but also the wider family's health with support during this period. However, this is the reality for women at this stage of life. So this slide depicts the experience of women, the competing demands on women's time. It's a really unique time for women during life. Their life changes completely when a baby comes along, and we shouldn't underestimate the complexities and the busyness of life for women. And women tell us, often when you speak to women in PPI work, in the qualitative literature that has been published, women tell us that they really want to get back to feeling like themselves after having a baby, but there's so much going on that that's really difficult. And this is a really nice quote from some qualitative research in 2011. As a mother, I think it's typical to say that a mother's needs always come last because you put everybody else before you. It's hard to find the time to take care of yourself because everything else is so demanding. And that is, we should never lose sight of this is what the reality is like for women at this stage of life. And women do want support with their health and their well-being at this stage of life, but we also have to recognise that there are many barriers to engaging in self-care at this time. So there's a real need for acceptable weight management interventions that fit into the busy lives of women. We need to consider the difficulties in reaching the postpartum population, and importantly, what works at other life stages might not necessarily work here when it comes to weight management. And we've seen that in the literature that very intensive behaviour change and weight management interventions that have required women to be in a certain place at a certain time to attend multiple appointments have really suffered from low recruitment and high dropout rates. The evidence to date supports the use of more adaptable anytime, any place, flexible approaches with postpartum women, but we really need good quality trials in this area. And there are quite a few studies now looking at diet, activity and weight management in the postpartum period. But a lot of the studies have been very small. Some have struggled to recruit to their target. The attrition rates have been very high in many studies, and engagement with the intervention approaches has been very poor. There's also been a lack of process evaluations and cost effectiveness evaluations, which are essential to understand if and how the intervention's working and would it be appropriate to implement it at scale. The duration of studies, as has been said by Nicola in her presentation this morning, a lot of the studies are very short-term with a focus very much on short-term weight loss and very little focus on what is equally important, which is maintenance of weight loss. And scalability often has not been considered at all in this work. What is encouraging and has already been touched on is that interventions that use modern technologies actually show promise specifically for this population, given their circumstances and reflecting all the competing demands they have on their time. So this call from the National Institute for Health Research came out in April 2014, seeking to find effective and cost-effective interventions for weight management after pregnancy. And we considered all of the evidence that was available up to that point and the voices of women, and decided to apply for funding for a text message delivered intervention in the postpartum period, and that became the Supporting Mums intervention. The reason we decided to go for a text message delivered intervention is that it's a really simple form of communication. No matter what type of phone you have, everybody can send and receive a text message. So sophisticated technology is not required. It's very much an anytime, any place, anywhere intervention, so women can engage with it when it suits them. It has the potential for broad reach across the socioeconomic spectrum, which is really important when we're considering health inequalities and not wishing to widen health inequalities. It can be used proactively and reactively in terms of communication, and there was good evidence in the literature that it had been used to change other health behaviours, like the text to stop smoking cessation intervention that was then scaled up by the NHS. It also allows sustained contact over the longer term, and that's really important for maintenance of behaviour change. And if you want to, it allows individual tailoring to be incorporated into the intervention as well. And a really important selling point is that it's low cost, so there's high potential for rollout and sustainability in the longer term. So the theoretical basis for the Supporting Mums intervention, I won't go into detail, but just to say that it focuses on 2 behaviour change phases. So months 0 to 6, we focus on weight loss, and that's guided by the health action process approach. And then months 7 to 12, we focus on maintenance of behaviour change, and that's underpinned by a systematic review of over 100 behavioural theories. So this is a 12-month intervention with a focus on both weight loss and weight loss maintenance in terms of behaviour change. We spent a year developing the library of text messages that forms the Supporting Mums intervention, working with PPI collaborators to do that, and full details of that are in the NIHR report from the feasibility work. So the first bit of funding we received was for a feasibility study that incorporated the intervention development and a pilot RCT, and that report has been published. In terms of the ethos of the intervention, it encourages a self-guided approach to diet and activity behaviour change and weight management. It incorporates selected behaviour change techniques based on available evidence in the literature about what behaviour change techniques are effective in terms of diet and activity behaviour change and weight management, and those are also linked to the underpinning theory for the intervention. We provide information in layers to avoid overwhelming women, provide information, advice, practical support, and we signpost to external resources, evidence-based resources, and that's really important because there's so much information available. It's really important to signpost to good sources of evidence-based information. The messages include real-life relatable situations relevant to postpartum women that we gathered through our PPI work and through looking at studies that had already been published in the literature, and addresses key barriers, specific barriers for this population. The messages are designed to provide encouragement, motivation, discourage guilt, but encourage self-reflection, and they adopt a friendly, accessible tone and include humour to encourage engagement. This slide just summarises the intervention components of the text message intervention. So it's fully automated and it's a 2-way text message delivered intervention. And all women receive a set of core messages across the 12 months. So about just over 350 text messages over the space of a year, focused on diet and activity, behaviour change with those embedded behaviour change techniques, and addressing general barriers to behaviour change, but also barriers that are specific for postpartum mums. We have interactivity built into the intervention in that women can text one of 4 trigger words at any time during the intervention if they want some immediate support. So those trigger words are tired, bad day, crave, and slip up. And when a woman texts the trigger words, the system will pick that up and send a response immediately from a list of responses that have been prepared. We also ask women some yes-no questions in the text messages throughout the 12 months, and they serve different purposes. Maybe prompts to remind women about the usefulness of setting goals, or to ask them in generally, how they've been getting on. And then women can reply yes or no, and again, that triggers a response from the system based on what they have replied. And then the other feature we have is to encourage self-monitoring of weight. We ask women to text us their weight every week. And that interactivity is at the discretion of women and how they choose to engage with it. We also have an option for women to sign up friends and family members if they want to for that social support aspect. So that's a buddy opt-in function that women can use. So after we developed the library of text messages, we proceeded to do a pilot randomised controlled trial in Northern Ireland. So we randomised 100 women from across Northern Ireland into an intervention group or a control group. The intervention group received the Supporting Mums intervention text messages, and the control group was an active control, and they received text messages about child health and development. And for the pilot study, the intervention was 12 months, and we followed up women at 0, 3, 6, 9 and 12 months. We visited women in their own homes to collect the research data. So for us, there was no point in having an accessible intervention if we didn't also make participation in the research accessible to women. So we visit women in their own homes, and that we followed that methodology for the full trial as well. Our inclusion criteria were women could be between 0 to 2 years postpartum, over 18, and a BMI over 25. So the feasibility work that we did, the intervention development and the pilot study, has been published in this report, and we had a number of stop-go criteria of whether we would proceed any further with the work based on recruitment, retention, acceptability and positive indicative effects. And we successfully met our stop-go criteria, which gave us the green light to potentially then progress to a full trial. But while we were, looking at the results from the pilot study and thinking about the next step, which would be a large-scale trial, we were very conscious of the research practice gap, and that a huge amount of research never actually gets translated into practice, and we can never really have impact unless we bridge that gap. So we had considered this, at the outset when we were developing the intervention, but in the move from pilot to full trial, we wanted to really focus on our trial methodology and how it could help bridge this gap. This is a really useful guide about scaling of population health interventions. There are many guides out there. I just particularly like this one and find it helpful. But what is really important and what is highlighted in guides such as this is you're more likely to be successful if you have a systematic approach to scaling up from the outset of your research. From the very first time that you think, I have a great research idea, you need to be thinking about how would this look in real life? We can do very fancy things in research and research settings, but how would that ever be translated into real life? And there are many factors that affect scalability. It's not just intervention effectiveness. So this guide provides a really nice step-by-step process that includes an assessment of scalability and really is very useful for policymakers, health practitioners, but also for researchers when you're starting to develop your research idea and design your interventions. So key things that we considered when scaling up from the pilot study to the full trial were generalizability. We wanted to do a study that would allow us to have some generalizable results, and therefore we needed to broaden our geographic reach, consider ethnicity and socio-demographic status. And to do that, we carefully chose the sites that we would do the study in and the recruitment methods that we would employ. We wanted to make sure that our work had an inequality lens built into it, and that's built in several ways, but specifically when you're using technology, you want to make sure that it doesn't unintentionally increase inequity and digital exclusion. For the full trial, we wanted to ensure that our recruitment approaches mirrored what would happen if this was scaled up and implemented. So how we approached women to take part in supporting mums should be how they might hear about the intervention if it was to be scaled up, for example, by the NHS or a health authority or public health. We also wanted to include some initial knowledge mobilisation work towards the end of the study that would inform our implementation and scale-up plans, and that work is interviews with stakeholders towards the end of the study. And as well as looking at cost effectiveness and the process evaluation, we wanted to have a longer term follow-up to look at longer term behaviour change. So for the full trial, we follow women up to 24 months, so 12 months after the intervention has ceased. So we received funding for the full trial in 2021, and for the last few slides I'll just update you on where we are with the full trial at the moment. This is the design that you saw for the pilot study and is also the design that we have used for the full trial, but this time our sample size was slightly larger, so we have recruited 892 women to the trial, and our follow-ups are 0, 6 and 12 months, and then that longer term follow-up at 24 months, 1 year after the intervention has ceased. Before we embarked on the full trial, we spent 6 months doing further adaptation of the text message library, and the aim of this was to review and adapt the library to ensure it was acceptable and culturally relevant for women across the UK and from different ethnic backgrounds, and we had a focus on things like the language and the humour, the clarity, the tone, the cultural relevance. And the stages that we used, I won't go into, but very much mirrored the process that we used in the feasibility work. So the text message library adaptation work, as I said, took us about 6 months. It was very reassuring that the mums who worked with us on that commented positively on the overall aim of supporting mums. So that was really encouraging, because before we had been doing the work within Northern Ireland, and they commented on the friendly, supportive and empathetic tone of the text messages. And the changes they suggested were relatively minor, so more tweaking the messages rather than having to rewrite large amounts of the messages. So where are we with the trial at the moment? We recruited over a 1 year period between April 2022 and April 2023, and we had 2,200 women who expressed an interest in the study. We screened 56% of those for eligibility, and just over 1,000 women were eligible to take part. Of those 1,012 women, 892 were randomised. So the translation rate from being eligible to randomisation was 88%, which is a really high translation rate for this type of study. Our recruitment took place across the UK, so we had 5 recruitment sites in all 4 countries, so Northern Ireland, Scotland, Wales, and we had 2 recruitment sites in Bradford and London, and that was specifically chosen to ensure that we could get the ethnic diversity in our sample that we wanted to. So we were definitely strategic about the sites that we chose, because we're never going to get that diversity in a sample of women in Northern Ireland. So we needed to make sure that we had UK-wide recruitment that would give us that diversity in the women. We do have an ethnically and socioeconomically diverse sample. An early indication of acceptability is that women can stop the messages at any time, just like any text message service. So far, not so far, because we finished the 12-month follow-up. So at the end of the intervention, just 2.5% of women stopped the text messages. We don't know if that was in the intervention group or the control group, because we haven't unblinded the study yet, but clearly that's a really encouraging indicator of acceptability in the full trial. And our follow-up rate has been really good, so we're very well powered for our outcomes. Our follow-up rate at 12 months is 76%. That includes all the women who have had to stop participating because they've become pregnant during the 12 months of the intervention. So when you remove the pregnancy exclusions, the follow-up rate is 85%. So we're really pleased and think that that speaks to the research methods that we use to try and make it as easy as possible for women to participate in the research, as well as hopefully the nature of the intervention. So finally, in terms of next steps, we've completed the 12-month follow-up, so we'll be analysing that data over the summer months, and the 12-month data will be available towards the end of 2024. We've just started 24-month follow-up with our women, so we've just started that process, and depending on the results of the 12-month analysis, we would then plan to do those interviews with stakeholders, which would then feed into the knowledge mobilisation and implementation work that we would like to do. In conclusion, we need scalable and acceptable weight management support that fits into the busy lives of women during the postpartum period. Digital interventions show promise, but we need to be mindful that we don't unintentionally widen inequalities through their use. In the Supporting Mums intervention, we've worked closely with and considered the needs of the target population at each stage of intervention development, and also regarding the research methods that we have used in our pilot and full-scale trial. Consideration of factors relevant to scale up have also been considered from the earliest design stages, and this trial will provide evidence on the effectiveness and cost effectiveness of this intervention. I'd just like to finish by acknowledging all of the collaborators and partners that we work with to deliver the Supporting Mums study across the UK and further afield, and also a big thank you to the Supporting Mums participants, our PPI collaborators, and our Trial Steering Committee, and Nicola is the chair kindly of our Trial Steering Committee, so a huge thanks to Nicola as well. Thank you very much for your attention.
Thank you. Thanks a million, Michelle. It's really fascinating to see that longer term follow-up and what we're going to gain from understanding a bit more about that. At this point, I'm going to ask all of our speakers to come back up to the stage, if you don't mind. We're going to start our panel Q&A session. So for those of you in the room, please raise your hand if you have a question and wait for the mic to arrive, because if you don't have the mic, those joining us online won't be able to hear your question. For those of you joining us online, you know that you add your question to the Q&A box, which is at the bottom of your screen. So really looking forward to receiving some of those questions. If you guys want to pop up, we can get started. Michelle, I suppose your presentation is freshest in the mind, and I might just get started myself. I was really taken by the PPI, the patient and public involvement aspect of your work, and I suppose that applies to, it's a real privilege to hear so much work that has included this aspect today. But also, Nicola, you had lots of quotes from experts and researchers that probably didn't show that kind of sensibility to the experience of the participants. So maybe Michelle, if you would start, and we'll talk a little bit about PPI and how important it is, and then if anyone wants to add anything to that, maybe we can do that as well.
Thanks, Aileen. It was really fundamental for us when we started when the NIHR call came out, and we started to think about, right, well, where would you start with this? And it was the voices of women that directed what we did, and that's where we started with. And I think sometimes there is redundancy in research because people do the same things over and over again, ignoring the previous experience of participants in previous studies. We were lucky at that time that there had been a few really nice studies, and that qualitative study by Montgomery that I showed a quote from, that really brought home what it was like for women in the postpartum period. And I was around that time myself, yeah, when do you stop being postpartum is a question for women, isn't it? But, you know, I fully empathised with what it was like. And when you looked at previous studies, it was like, well, no wonder that didn't work, or no wonder women didn't engage, or no wonder women didn't like it, because it wasn't designed for women at that stage of their life. But also, it was really important for our research methods, and equally, you know, in terms of designing the trial. But, you know, women contributed much more than just developing the library of messages. Our PPI collaborators, you know, helped us design the ethical materials, the participant information sheet. They chose the name of the study, and you know, they helped ensure that our lay summary communicating the results was appropriate. So just, you know, really, I think that it's a huge waste of resources for any research to proceed without PPI inbuilt into it from start to finish.
Anybody want to add anything there?
I guess just a similar thing in relation to the pregnancy interventions. So we do have, you know, multiples of hundreds of pregnancy interventions for weight management and maternal obesity globally. And my heart just sinks when I see another pregnancy intervention coming out that looks no different to any of the ones that have been before. And we really need to, I feel, just stop and learn from what's gone before to try and make sure that the interventions, that we're learning from those interventions, what worked, why did it work, what didn't work, why didn't it work, and that we're actually making interventions better rather than just repeating, because it is such a huge waste of resource. It's a waste of research money, but it's also really unethical to put participants through an intervention when it's not, you know, you haven't learned from what's gone before to try and make it the best intervention it could be as well. And yeah, PPI is a huge part of that, alongside learning from what's happened previously.
Great.
Yeah, I suppose I can only add to agreeing with what is being said there, because in the run-up to, say, for example, doing Bump to Baby and Me, we did really, really extensive examination of the literature to try and unpack what were the successful ingredients for implementation and what were the things that we could see clear signals from the extensive literature that already existed. And that holistic piece and having the mum driving the things that she wanted to get out of her coaching was something, rather than going in with an agenda and saying, well, this is our cookie cutter type intervention and I'm afraid you're going to have to fit into it, rather than thinking about, right, well, what are the things that you want to work on? We're not saying that everybody coming into this intervention needs X or needs Y. Trying to put the mother back at the centre of the intervention and making sure that it could sit, in our case, it was alongside usual care, rather than trying to create an intervention that was going to intervene with the flow of the health system, because that's where you've got problems with sustainability, because if you don't have funding within the health system to keep something going, then you're going to have challenges of recruiting people across a system that's potentially not going to be sustainable in the long run.
Thank you. I have a question here from one of our online participants. Nicola, is there evidence of a cumulative impact of inequality, food insecurity and obesity? So an interesting one.
Yeah, so I guess that that relates to that intersectional inequality. So we know the more adverse events somebody's exposed to, the more likely they are to develop obesity. And we see some great work from Keith Godfrey's team in Southampton looking at the cumulative early life exposures to adverse or risk factors and how that impacts on childhood obesity development from that pregnancy as well. So there's definitely this cumulative risk with the number of adverse exposures. I think in the context of food insecurity, it's just such a new, rapidly emerging issue in high-income countries that we don't know enough about it yet outside of North America, which has very different kind of social care contexts and healthcare contexts. So we really need more evidence. But we do know that food insecure households are more likely to have women and children in, that they're more likely to be minoritized ethnic groups in food insecure households, that people who have a disability are more likely to be in food insecure households. So all of these things definitely overlap. We can't just go, right, well, you've got food insecurity, you've got something else. There is that, the intersectional kind of inequalities are really important.
Thank you. And Michelle, I have a very specific question for you here. Was the traveller community represented in the participants in your study?
We recruited, I don't know, because I don't know, is the answer to that. But certainly our recruitment approaches were very broad. So we used, we did some recruitment via healthcare professionals. We recruited via community networks, already established networks in communities. We recruited through the Bourne and Bradford cohort. We did use social media advertising on Facebook, but we also, working with community groups, mums and baby groups, local libraries, etc., they also posted on social media, and we recruited that way. So I don't know specifically, because we haven't looked at that data, but certainly, I mean, that would be interesting to see, and I think we wanted to test the range of recruitment approaches and see, because one thing we will look at shortly is who was recruited by those different approaches, who was recruited by social media, who was recruited through health professional contact, who was recruited through a trusted source like a mum and baby group posting on social media versus a paid for ad on Facebook. So we will have more data on the success of the recruitment approaches and who was recruited as a result of that. And Donla, who's the trial manager, is working on a recruitment paper at the moment.
That'll be really interesting to share one of your points around sharing and learning. So that's fantastic. Rosie, I'm going to come to you. I suppose I was struck by the funding by the sporting body, but then the openness, or maybe not, I don't know, in terms of the outcomes and the methodologies that you're able to employ. So, I mean, we, at Safefood and others, we love to think about food and food interventions as a vehicle to other services and other types of health outcomes. And of course, your trial took that approach, but the funding body was very specifically Sport England, and they would have been looking for physical activity outcomes. How did all that work? How did that conversation go? And was it a challenge really, or yeah? Yeah,
and I mean, I think the biggest challenge for me being kind of involved with Sport England was around the measurements that they wanted us to use initially. So they were very focused on using weight as a measured outcome and using BMI as a measured outcome. But I have to say they were particularly good when we used the power of talking about PPI, we used the power of the women's voice. It wasn't just that actually we've changed our mind, we want to measure something else. It was, well, look, this isn't actually just the issue on its own, and if we don't tackle these other things, if we don't look particularly at well-being and look at it more holistically, then actually we're never going to change those physical outcomes that you're more interested in. So they were quite open to that, as long as we still measured the BMI and we still measured the weight alongside other things. They were quite open to that and using that as part of the funding. And it is a problem, I think, for lots of things we use BMI as a measurement, and also even thinking about the guidelines for fertility treatment. Your cut-off is often based on, when I think about all of our maternity guidelines, they're based on a BMI, because it's very easy to measure. It's easy to have someone in front of you measure their weight and their height, and there you have this magic number, but we know that it's so much more than that.
Thank you, Rosie. I have a question here, and it may be possibly yourself, Sharleen. It says the duration of puerperium is usually 6 weeks, except for the leading cause of maternal mortality, which is suicide, where it's counted for 1 year postnatal. Is there a link with Perinatal Ireland, which is a cross-border organisation? I don't know if anyone is involved in that here. No.
No, but I suppose I could mention the fact that typically studies start in pregnancy and just go for the duration of the pregnancy, or do postpartum and go for the duration of a set time point postpartum. There's very few that actually cross that period. Mm-hmm. And as this person is highlighting, it's a period of stress for the mum, that she's being dropped into potentially a new situation where she's parenting for the first time maybe. There's the risk of postnatal depression and psychosis. You've got issues in terms of trying to get breastfeeding started, sleeplessness, all the things that come with the joys of being a parent are exacerbated and potentially within that period challenging. So I suppose having interventions that run across those two spectrums are something that we know came from our engagement with women, was that they felt like they were dropped by the health services once they'd had their baby. Their job was done. I mean, there's some very clinical comments that are made by women saying, I was just a baby incubator. You know, those kinds of terms are, you know, what people feel about pregnancy sometimes. And so as a result, having something where they had a touch point, somebody like our health coaches who are allied health professionals, that they could go back to them and say, listen, I'm really struggling. Or that the health coach was checking in on them. They said for them made real the ways with which they could access support, you know, so that they weren't on their own. There was somebody there to help support them. And I think that's quite an important thing that we need to think about when we're developing interventions to look to support women, is that it's not just going to fit in that box of being pregnant, not being pregnant. I think we need to think about it more holistically. It's a life course thing. We need to think longer term, but unfortunately it's hard to do those things, and I think we need to think a little bit smarter about how we use the resources that we have available to us to get the better outcomes for mums when they need it.
Thank you, Sharleen. And I'm going to stay with you just for a moment, and we have a question here from our online audience. From the evidence you reviewed prior to Bump to Baby, what were some of the main characteristics of successful projects?
Yeah, so we looked at both the pregnancy interventions as well as interventions that occurred postpartum, because we were obviously interested in both those time points. The key characteristics that we found were interventions that were delivered by healthcare professionals tended to be more successful, so that trusted information source seemed to be really important. For interventions in pregnancy, physical activity on its own didn't seem to make much difference, but we did see when we looked at it that diet-specific interventions where there was good contact over a relatively short period of time worked well. Equally, combined interventions weren't as effective, but they were the next best thing, so physical activity and dietary components. But in the postpartum, it was very mixed. You could have it delivered in more remote forms. That was quite acceptable. Whereas in pregnancy, they wanted to have a relationship with the person who was delivering it and to trust that individual. But in the longer term, they saw mHealth as a thing that would actually be suitable. And the degree of contact actually didn't have to be high intensity, because again, that's a problem at a health service level. If you've got a really high contact intervention, you physically can't deliver it at a health service level. So it was good and reassuring that lower levels of touch, but at times that suited the mother, were actually some of the key things that they wanted, and that their child was a major motivator for engaging in interventions in the postpartum period, like you were talking there about, Michelle. And then in pregnancy, it was about a more holistic piece about themselves, but maybe thinking about their child as being a component of that too.
Thank you. Sure, Michelle, a quick one for you. Were the text messages developed for the study published?
No. No, they are not published. Yeah, I mean, I guess we you know, certainly I've had some conversations with people who are keen to use them in other contexts and you know, maybe in other countries, etc. And ultimately, you know, if shown to be acceptable and it's, you know, has positive effects, we want this intervention to be used. So that is the idea, that you can take this library of text messages and you can implement it on a text message platform. And there are so many text message platforms out there, but you can take it and you can implement it anywhere with the right text message platform. So I suppose that transferability is potentially another plus point for using a text message intervention, but they're not published at the moment. But I think, watch this space, and definitely we will want to share them. That's the purpose of doing this work, is to make an impact.
Yeah, absolutely. I am being given time warnings here on the screen in front of me, so thank you for my colleagues for keeping me right. John, I haven't had a chance to ask you a question, but I do have some of the comments from online in front of me, and I would like to share those with you. That was one of the most incredible, articulate, powerful talks that I have ever heard in my life. Keep telling your incredible story. Is there anything you'd like to add, having heard all of the other speakers today and participated in the panel?
Yeah, well, it's lovely to hear. It's nice to hear the comments, like when you're laying your life story bare to people. But as I said to some at the break, that it's important to share. It's important to give that learning experience as well too, as the academics are doing here, and they're mixing the qualitative with the quantitative, which is very, very good as well too, and getting very practical outcomes from it as well too. But yeah, for I suppose any patient advocates is that positivity. To me, that's what needs to happen in mothers' lives, prospective mothers, existing mothers. It's not easy. There's no question about that. And change, positivity and change, and embrace change as a positive element of your life journey. Because certainly, as I say, if I could have had a gastric bypass many years ago, and I took that intervention to help me with my weight loss, that would have changed, I think, my life direction. But that's in the past. You can't do that. As I candidly said to my son, I cannot change the past, but I can certainly deal with the now and influence the future. And I think this is a forum that is certainly pushing that forward as well too, and that's to be commended for everybody, all the speakers, and also everybody attending and everybody listening online. This is how we make progress as human beings, and it's not just the numbers. There's qualitative there too.
Thank you so much, John. Our last speaker today, Laura McGowan, is going to try and sum up all of that rich material for today. Thank you for doing this, Laura. Thanks to yourself from ASO, the Northern Ireland Network, and to Niamh from ASOI, and indeed to Nicola, who's the chair of the Board of Trustees for ASO UK. So we have collaborated very closely with our colleagues in ASO on this, on developing this conference, and that's why we've got such a high quality of speakers. So over to you, Laura.
Thank you.
Take my debris with me. Thank you.
This okay? Yeah, got me. Okay, thank you so much for the invitation to be able to give the closing remarks today, and again I'm delighted to be involved in this kind of joint event between both the UK Association for the Study of Obesity Northern Ireland Network and also ASOI. So I just want to start off, I will be brief, don't worry, but I do want to start off by thanking Safefood, Aileen and Daniel and so on for their excellent work in putting today's event together. Thanks also to Niamh for her powerful words in opening on behalf of ASOI. I do want to especially thank John. Though John and I have the pleasure of getting to know one another over the last while, and I think I agree with the quote that was read out for you, the comment. Your story was so open and moving, really frank, and as I said to Nicola earlier, as researchers sometimes we stand up and we hide behind the numbers and we say the evidence says and the research shows, but actually you got up there and laid your personal life bare. So thank you, because I certainly took a lot from that, and I hope others do as well. So my closing remarks, I'm going to focus on three key things. And actually the first point links in to something that John brought up. So you really highlighted the importance of this multidisciplinary input, I think, you know, especially regarding psychological and mental health support for those who are undergoing fertility, their fertility journey, and especially for those living with obesity and who are undergoing that, where I think we really aren't doing enough. And Rosie and I had a conversation about that and the things that we offer, for example, in Northern Ireland, back when I was able to be involved in the steering committee for LIFT. I think that's an extremely important point, and we don't want to lose sight of that. So any opportunity we have to influence those things, we should be taking the opportunity to do so. I think that it really highlights the value of having lived experience front and centre at the table. So, you know, John, I hope that you continue with sharing your story and influencing the research and the services that we offer to people. My second point is somewhat linked to the first and builds a little bit on what Rosie presented with all of her beautiful results from the kind of pilot LIFT trial. So as a psychologist by background, I love hearing the biopsychosocial model being wheeled out. So I really enjoyed your Venn diagram with all of the different outcomes. And it really did make me think, though, on a serious note, you know, we need to think smarter about the types of outcomes that we are measuring, not only within the research community and as clinicians and so on, but the way that we do that is by thinking what matters to the people that we are developing these interventions and services for. And again, back to our point of having that lived experience front and centre at the table from inception is a way that we can make sure that we are making our interventions and our programmes of research more impactful to those who we are there designing them for in the first place. So that's really the second point. And then finally, I think my third reflection is again linked to some of the points made by Sharleen and Michelle, is that we need to think more holistically about these interventions to support people across the reproductive stages, whether that's women, men, birthing people and others. We need to think holistically about those interventions that span across those reproductive stages. And I think we do need to get better at identifying the gaps in the current literature, building on the evidence where we have it, as Nicola alluded to, in pregnancy, not reinventing the wheel, making sure that we are at a critical moment where we stop and take stock of what we have, what knowledge we've gained, and where can we find those new avenues for further research without just reproducing existing evidence. And I think that that's really critical. And actually, I think that the key change in all of that will also come from the greater involvement of lived experience, as we've proved here today. So that's it from me, and in a combination of both John's words and my own, it's been inspiring, informative and emotional, so thank you.
Thank you so much, Laura, for summing all of that up so beautifully. It's time to say goodbye now to our online audiences. Your screen now will be replaced with a QR code. There's no such thing as a free lunch. And if you would please fill out our survey to help us make these events better the next time. If you provide email, we will also give you a certificate for attendance. So thank you so much for joining us online. Apologies for the extra time that we had to take just to make sure that we could cover everything in our conference today, but we appreciate your attendance.